PY 4.2 সিক্রিশন যে পার্টটা বাকি ছিল তার সাথে হচ্ছে জিআই মুভমেন্টস। তোমাদের যে চার্ট দেওয়া হয়েছে তাতে দেখবে জিআই মুভমেন্ট। তো ইনকমপ্লিট পার্ট অফ PI 4.2 will be over, তারপর GI movement I will start. If something is left, mostly there's a possibility something will be left that will be covered in the next class, kind of that. So today main focus will be bile. Our main focus will be on bile, and last day I finished at the difference between liver bile and gallbladder bile, if you remember. Liver bile and gallbladder bile, and liver bile is a greenish yellow viscid fluid which is a kind of, the product of excretion from the hepatocytes, and it contains a number of substances which we will be discussing in some time. And gallbladder, which is just beneath the liver, it is used as an organ to store the bile. And since bile is stored in gallbladder, the chemical component, chemical nature of bile changes while it is stored in gallbladder. In any book you will see the differentiation between these two, but the major factor is gallbladder does three things to bile. First of all, it dehydrates the bile, because in the gallbladder epithelial tissue, water is absorbed. So as water is absorbed, liver bile component, water component is 98%. In case of gallbladder, it comes down to 89%. Second, it acidifies. That's the second thing. And the third, just as a continuation of the first point, solid level in gallbladder increases. So level of cholesterol, level of bile pigment, level of bile salts and bile acids, concentration in gallbladder bile increases. Now, then again, I think you remember the anatomy. From the gallbladder, cystic duct comes out, and this cystic duct gets connected with the common hepatic duct, and it forms common bile duct, and this common bile duct opens up in the periampullary region, ampulla of Vetter near that, opens up into the second part of duodenum, and before that it is connected with pancreatic duct. And there is a very important valvular structure, sphincter of Oddi, that you know. Now what we need to know in this particular, that is anatomy, the different thing. What we want to know here, that normally when suppose we are not eating anything, we are in fasting state. Now in fasting state what happened? Liver is continuously draining bile, and that bile is coming into the gallbladder. But that bile in fasting state, it doesn't have any action. So what it does, it sits in the gallbladder, and gallbladder is, during the fasting state, gallbladder distends. কারণ কি ওর মধ্যে বাইলটা জমা থাকছে। There is no need of bile in fasting state. বাইল করবে কি? বাইলের যে ফাংশন আছে, that is all in the intestine. Bile main function is in the intestine. Now if there is no food in the intestine, there is no action of bile, so bile will be stored there. And since bile is stored, there is no flow of bile from the gallbladder system or biliary system to the intestine. So sphincter of Oddi as a valve, it will remain closed. তাহলে ফাস্টিং স্টেটে গলব্লাডার, এটা ইউএসজি করলে দেখা যায়। সো ফাস্টিং স্টেটে gallbladder remains distended, sphincter of Oddi is closed. Fed state, the moment food enters the intestine, there's a need for bile to be present over there. So gallbladder contracts, sphincter of Oddi opens, bile passes into the intestine. Clear? এই জিনিসটা খুব important clinical concept. Clinical concept. So gallbladder size will be variable depending on fasting or fed. Clear? বোঝা গেল জিনিসটা? So এই জিনিসটা এলো। এইবারে আমাদের যেটা বুঝতে হবে যে bile secretion, it has multiple factors that acts on bile secretion. There are two basic things. One is BAIF, the another is BADF. BAIF ki bile acid dependent flow, BADF, and BAIF is bile acid independent flow. What does that mean? That bile secretion can be independent of bile acid presence, or bile secretion can be dependent on bile acid present. Now dependent on bile acid jeta, that happens in the fed state. Dependent on bile acid, that happens in the fed state. Independent on bile acid, that depends on the fasting state. Clear everybody? এটাকে আমি আরো এক্সপ্লেইন করব। So first of all, এইবারে we are going back to the board and we will write the components of bile and something like that. Okay, clear? So components of bile, আচ্ছা বাইলের কম্পোনেন্টের মধ্যে ফার্স্ট ইজ বাইল সল্ট। সো বাইল সল্টগুলোর মধ্যে কি কি বাইল সল্ট রয়েছে, and what are bile salt? As you know, salt is the cationic conjugate with acid. So usually this is salt কি কি থাকে, টরোকোলিক অ্যাসিড, গ্লাইকোকোলিক অ্যাসিড, এগুলোই তো সল্ট, অ্যান্ড এদের যে সোডিয়াম অ্যান্ড পটাশিয়াম সল্ট ইজ বাইল সল্ট। নাও বাইল সল্টস আর বেসিক্যালি sodium or potassium conjugate with bile acid, and these acids are usually taurocholic, glycocholic, এই টাইপের অ্যাসিড গুলো হচ্ছে। Important concept here that there are two different types of bile acid. One is primary bile acid, and the second is secondary bile acid. So primary bile acid is the actual bile acid that is secreted in the liver. এটার মধ্যে রয়েছে হচ্ছে কোলিক অ্যাসিড or chenodeoxycholic acid. So these are the primary bile acid, they are formed in liver, and these are cholic acid. Maximum হচ্ছে cholic acid ই থাকে, আমাদের যত bile acid আছে half of them is cholic acid itself, বাকিরা কম পরিমাণে রয়েছে, and the second one is chenodeoxycholic acid. So why these are primary? Because bile's primary preliminary source is liver, they are formed in liver. That's why they are primary. Now try to understand, this bile comes through the hepatobiliary system, goes into the intestine, and in intestine there is normal flora. Flora মানে bacteria. Remember আমাদের বডিতে যা কোষ আছে তার থেকে many more times bacteria are there. They are in symbiosis with us. Trillions of bacteria are there. These are gut microbiota. এটাকে বলা হয় gut microbiota. And a lot of things, recent researchers are suggesting তুমি কিরকম চিন্তা করবে, তোমার মুড কিরকম থাকবে, ইভেন পরীক্ষায় কিরকম পাবে, সেটাও ডিপেন্ড করছে অন দি gut microbiota. এবং এই জন্য উল্টো পাল্টা অ্যান্টিবায়োটিক খাওয়া, যখন তখন অ্যাসিডিক অ্যান্টাসিডগুলো খাওয়া, দে আর ভেরি হার্মফুল টু ইয়োর gut microbiota. We have a symbiotic relationship with them, and they are responsible for many things, including nutrient synthesis, nutrient absorption, water absorption, various modulation of neurotransmitter. Serotonin level ki thakbe, norepinephrine level ki thakbe in the ENS. Gut microbiota is a very important responsible factor there. Clear? এই জিনিসটার জন্য পরবর্তীকালে জানবে, যেমন there are certain GI diseases যার জন্য আমরা antibiotic use করি. Antibiotic is what? They will kill the bacteria. Now there are also, now নয়, এটা 30-40 years ধরেই চলছে, there is also a concept of probiotic. Probiotic is অনেকেই ইউজ করবে, বিফিল ল্যাক্টোব্যাসিলাস ক্যাপসুল, অনেকেই জানো ল্যাক্টোব্যাসিলাস ক্যাপসুল কার্ডে থাকে, এমনি ল্যাক্টোব্যাসিলাস থাকে। সো এইগুলো খেলে অনেক সময় আমাদের সে পুরনো সিস্টেমে বলতো না যে পেটটা ঠান্ডা থাকবে, ওয়াই? they had an inherent wisdom কে এই জিনিসটা খেলে বেটার হয়। বেসিক্যালি দ্যাট ইজ আ gut microbiota, সেইটা যাচ্ছে এবং গিয়ে কি করছে, they are competing with the harmful bacteria inside the stomach, inside the intestine. Harmful bacteria যারা ডায়রিয়া করছিল, your own helpful bacteria, they are helping them. Clear? তাহলে just by giving gut microbiota capsule we can solve certain issue. এবং এখন একটু ডিফিকাল্ট লাগতে পারে, also remember one term called fecal transplant, stool transplant. Can you imagine? There is some condition যেখানে stool, পেশেন্টের নিজের stool transplant করা হচ্ছে, it is again put into the intestine. Definitely not through mouth, but definitely you can put it into the intestine, or even if through mouth, that is through a tube. You don't have to go through that ordeal basically, and that is not exactly the primary form, that is some purified form. সেটাও কিছু কিছু ক্ষেত্রে in some specific type of diarrhea that is used as a last sort. সেইটা এখন আমাদের যে নর্মাল ডায়রিয়া, we are not talking about that. That is something different. এক্ষুনি বুঝবে না, next year onwards you will be accustomed to certain terms, তখন এই জিনিসগুলো ফিরে আসবে. So basically my main motto here to impact this one into your mind, that gut microbiota, our own bacteria, those are friends to us. So let's be a little soft to them during your prescribing. Just don't mindlessly prescribe antibiotic. That will also kill them, and that actually leads to, দেখবে অনেকগুলো অ্যান্টিবায়োটিক খেলে ডায়রিয়া হয়, অনেকগুলো অ্যান্টিবায়োটিক খেলে শরীরটা এক্সট্রা খারাপ লাগে, যে লোকের জন্য গেছিল তার থেকে বেশি খারাপ লাগে। বিকজ মাইক্রোনিউট্রিয়েন্টের ওই পুরো এনভায়রনমেন্টটাই নষ্ট হয়ে গেছে। ইট টেক্স আ লিটল বিট অফ টাইম। ক্লিয়ার হলো এই জিনিসটা? ওকে, নাও কামিং ব্যাক। সো বাইল অ্যাসিডের মধ্যে দ্যাট ইজ দ্য লিভার বাইল, ইট ইজ প্রাইমারি bile acid, cholic acid, chenodeoxycholic acid, and there is secondary bile acid. These are formed in the intestine, and these are formed in the intestine by the action of gut bacteria. And one such is lithocholic acid. Lithocholic acid. So gut bacteria ta form korche. Primary bile acid যখন intestine আসছে তার উপরে gut bacteria is acting and this is being formed, lithocholic acid. That's one aspect of the thing. Clear, everybody? Bile acid you have understood, bile salt you have understood. Now there are bile lipids. Bile lipids এগুলো সব বইতেই আছে, আমার কাজ হচ্ছে জাস্ট কনসেপ্টটাকে ব্রাশ আপ করা। ভ্যালুজ আর দেয়ার ইন এভরি বুকস। পরীক্ষার আগে কিছু জিনিস মুখস্থ করতে হয়, এই ক্লাস সেজন্য নয়, সেটা পরীক্ষার আগে তোমাকে নিজেকেই মুখস্থ করে আসতে হবে। মাই আইডিয়া ইজ টু ইম্প্যাক্ট ক্লিনিক্যালি কোন কোন জায়গাতে তোমাদের জিনিসগুলোকে লাগছে। সো লিপিডস, বাইল লিপিডস এর মধ্যে ভেরি ইম্পর্টেন্ট ওয়ান ইজ কোলেস্টেরল, অ্যান্ড উই অল নো অ্যাবাউট ইট, অ্যান্ড দ্য সেকেন্ড ওয়ান ইজ লেসিথিন। সো দিস ইজ আ কাইন্ড অফ ফসফোলিপিড which is present over there. Bile lipids, they are bile lipids. So again remember, cholesterol transport, liver is a heavily dependent area. Cholesterol transport ta kintu liver er through te maximum cholesterol transport, be it good cholesterol, be it bad cholesterol, liver ekta marattok jinish. Ebong also remember, outside theke tumi cholesterol nao or na nao, body will make some cholesterol on its own. Kajei ডিমের কুসুমটা খেলে কি না খেলে hardly matters. So that's right now, definitely refined carb marattok khaccho, a lot of pasta, pizza, etc. Definitely your cholesterol will go up because there is also hepatic steatosis, fatty liver hocche ei jinish gulo khele. Kintu most of the time tumi kichu khao ba na khao, cholesterol is very important for our bodily functions, mainly reproductive function and neurological function. Cholesterol diyei to amar neurological function gulo hocche, biomembrane, most of the biomembrane that has lipids, that has cholesterol or derivatives from cholesterol. Do not, do not be very harsh on cholesterol. Again, kichu guidelines definitely ache, LDL level এর নিচে থাকলে with the help of certain other things, family history আছে কিনা লোকটার, স্মোকার কিনা, বিপি আছে কিনা, অন্য কোমরবিডিটি আছে কিনা, depending on that we need to reduce the cholesterol level. ট্রাইগ্লিসারাইড ভীষণ বেশি থাকে ইন্ডিয়ান ডায়াবেটিক্সদের মধ্যে, একটা there's a term called diabetic dyslipidemia, triglyceride ta beshi thake. The target here to reduce the refined carbohydrate. Always remember, protein, fat and carbohydrate er moddhe if there is any exact enemy, that is the refined carbohydrate, high glycemic index carbohydrate. Fat will not make you fat, sugar will make you fat. Fat will not make you fat, sugar will make you fat. And fat keno tomake fat korbe na, we are coming to it. GI movement e arekbar amra aschi. Fat keno fat tomake korbe na, fat khele mota hobe na, sugar theke mota hocche loke. Try to understand, okay? যেগুলো হচ্ছে যে আমাদের refined sugar, high GI sugar, those are causing this weight gain, excess calorie. We are coming to that. এই কোশ্চেন আসে। And এরপরে আসছি হচ্ছে bile proteins. So bile proteins can be many times. There might be IgA, there might be some other proteins. IgA হচ্ছে immunoglobulin A. Just মাথায় রাখবার জন্য, that is bile also contains some protein, but it doesn't bile components. This is all about the bile components. So next in line we have the secretion, control of secretion of bile. Bile ta ki kore কখন কতটা বাইল বেরোবে, সারাদিনই লিভার থেকে বাইল তৈরি হচ্ছে। ট্রাই টু আন্ডারস্ট্যান্ড, তুমি খাও আর না খাও, লিভারের কাজ, হেপাটোসাইটগুলো বাইল তৈরি করে যাচ্ছে। যদি সেটা কাজে লাগে, দ্যাট উইল গো ইনটু দি ইন্টেস্টিন। যদি সেটা কাজে না লাগে, দ্যাট উইল গো অ্যান্ড গেট স্টোরড ইন দি গল ব্লাডার। দ্যাটস দ্য হোল প্রসেস। নাও দেয়ার আর ফিউ থিংস হুইচ উইল ইনক্রিজ দি ডিনোভো সিনথেসিস অফ বাইল রেট। তুমি কয়েকটা সময় লিভার বেশি কাজ করছে, কয়েকটা সময় লিভার কম কাজ করছে। কিভাবে জিনিসটা হচ্ছে? সো তার দুটো ফ্লো বলা হয়েছিল, ওয়ান ইজ BADF, নাও আই এম গোয়িং টু ডিসকাস দিস, দি আদার ওয়ান ওয়াজ দ্য BAIF. So this is bile acid dependent flow, bile acid independent flow. I think you can follow. bile acid dependent flow, bile acid independent flow. Now, there is a circulation, we call it enterohepatic circulation. Enterohepatic circulation. সেই জিনিসটা কি? সেই জিনিসটা হচ্ছে লিভার থেকে ইন্টেস্টিনের টার্মিনাল আইলিয়াম অব্দি জিনিসটা আসছে বেসিক্যালি all the flows, all the secretion from liver through that pathway, hepatobiliary pathway, CBD, ampulla of beta, second part of duodenum, third part jejunum, kore terminal ileum obdi asche, and from there again it is going back to liver. This is enterohepatic circulation. This is a portal circulation. So this is enterohepatic circulation. Tate ki hocche amader sara dine bile acid total daily need is more than 36 gram or so. But we create 8 gram to 10 gram of bile acid in a day. So, tale 4 times need we have, and that is possible due to this recycling through the enterohepatic circulation. Bile jeta toiri hocche, it goes to the ileum, terminal ileum, which is the terminal part of the small intestine. From there, it again comes back to the hepatocyte. So this is the bile acid jeta come back korche, recycled bile acid that causes BADF, bile acid dependent flow. Tale once again, bile acid received from enterohepatic circulation, increases flow of bile acid in liver. So it is a recycled thing. এই জন্য bile acid এর একটা নাম আছে, and that is cholerectic. Cholerectic means the substance that increases the liver secretion of bile, and bile acid is the strongest cholerectic. পরীক্ষার কোশ্চেন। So cholerectic হচ্ছে bile secretion, লিভারের হেপাটিক bile secretion আউটপুটটা যে সবচেয়ে বাড়ায়। হেপাটোসাইটের মধ্যেই তো তৈরি হচ্ছে বাইল। ফ্যাক্টরি বাইল সিক্রিশনটা যে বাড়ায় সে হচ্ছে কোলেরেক্টিক, and that guy is the bile acid. Usually it is not the same bile, it is rather the recycled bile. এবং এই রিসাইক্লিং হওয়ার জন্য even if you are creating 8 gram of bile a day, 4 times, 7 times, 10 times whenever it is recycled, you are getting the actual value. সারাদিনে 40 গ্রাম বাইল লাগে, 8 গ্রাম তৈরি করছো, 5 বার ঘুরিয়ে দাও। Clear everybody? That is happening. That is enterohepatic circulation. Enterohepatic, intestine, liver circulation. Saradin ঘুরছে। Clear? So bile acid increases the secretion of bile acid itself. This is known as cholerectic. There is another thing. একটু আগে বললাম গল ব্লাডারের মধ্যে বাইলটা স্টোর হয়েই থাকবে। সেকেন্ড বাইল ডাক্টে, সেকেন্ড পার্ট অফ ডুওডেনামে কি করে আসবে? It requires sphincter of body to open. So there are certain factors which causes the opening of sphincter of body, and that happens only when you are taking some food. তাহলে যখনই আমরা খাচ্ছি একদম প্রথম দিন থেকে ভাবো, খেলে প্রথমেই নিউরাল রিফ্লেক্স, ইভেন ইফ ইউ লুক অ্যাট সামথিং, নিউরাল রিফ্লেক্স, ভেগাস নার্ভ ওপেন আপ হয়ে যাচ্ছে। সো দ্যাট ইজ ওয়ান রিফ্লেক্স। সেকেন্ড ইজ কেমিক্যাল রিফ্লেক্স, সেখানে কিছু এনজাইম এন্ড হরমোন কাজ করছে। সো ইউজুয়ালি CCK-PZ, cholecystokinin, it causes contraction of gallbladder and opening of sphincter of body. It causes contraction of gallbladder and opening of sphincter of body. কখন CCK-PZ বেরোয়? CCK-PZ secretion increases whenever there is presence of fat in the duodenum. Clear? তাহলে means fat মানে কি? Presence of fat and protein means presence of food in the duodenum. So in the fed state only this happens. So secondary thing that we need to remember here, that was cholerectic, and this one is whenever you are taking some food, so fed state, usually feeding with fat plus protein, and they are present in duodenum, that will lead to increased secretion of CCK-PZ. This CCK-PZ will cause contraction of gallbladder plus opening of sphincter of body, and that will lead to bile release in intestine, bile release in intestine for its work. So এই যে ঘটনাটা ঘটছে, this action is known as cholagogue. So CCK-PZ is cholagogue. This is the spelling. কোলাগগ হচ্ছে জিবি কন্ট্রাকশন করে যেটা বাইলটাকে সিক্রিট করছে। তাহলে কোলেরেক্টিক হচ্ছে বাইল ফরমেশন বাড়াচ্ছে, কোলাগগ হচ্ছে বাইল পালসেটাইল রিলিজ বাড়াচ্ছে। ক্লিয়ার? সিসিকে-পিজেড হচ্ছে কোলাগগ, আর বাইল অ্যাসিড হচ্ছে কোলেরেক্টিক। একদম পরীক্ষার কোশ্চেন নাম্বার 3 গ্রুপ সির কোশ্চেন আসে শর্ট নোট হিসেবে, দিস ওয়ান রিমেম্বার। এবং পরে ইভেন অসপিতে আসতে পারে, আর তোমার এমসিকিউ গুলোতেও আসতে পারে। ক্লিয়ার এভরিবডি? ক্লিয়ার? তাহলে বাইল, আচ্ছা, আর বিএডিএফ বিএআইএফ এর মধ্যে বিএডিএফটা বুঝে গেলে বাইল অ্যাসিড থেকে, বিএআইএফ হচ্ছে বাইল অ্যাসিড ইন্ডিপেন্ডেন্ট ফ্লো। সিসিকে-পিজেড থাক না থাক, বাইল অ্যাসিড থাক না থাক, লিভার তো কাজ করছে। সো দ্য হোল ডে লিভার ইজ সিক্রেটিং, সিনথেসাইজিং অ্যান্ড সিক্রেটিং সাম অ্যামাউন্ট অফ বাইল। দিস বাইল ইজ ইউজুয়ালি মোর ওয়াটারি ইন কনটেক্সচার। ওয়াটার বেশি থাকে, তাতে অ্যাসিডটা কম থাকে, বাইল অ্যাসিড কম থাকে। More water, more salt, more bicarb. And this is under the action of secretin. Hormone নাম হচ্ছে secretin. So BAIF হচ্ছে irrespective of bile acid, irrespective of enterohepatic circulation, irrespective of cholagogue action of CCK-PZ, this is the continuous bile flow. তুমি খাও বা না খাও, এই বাইলটা তৈরি হবেই লিভারে। Remember only one difference, this is not as thick as the actual bile. It is there, it's a secretion, and it is under the action of hormone secretin. Tale, it is BAIF. This is, we can call basal bile flow. Basal mean whole day. Basal bile flow. It is under the action of secretin. ACCRITIN. It is again a GI hormone. BAIF. Eita hocche control of bile secretion. Function of bile. Now again, very important area, function of bile. Bile doesn't contain any digestive enzyme. Bile doesn't contain any digestive enzyme. Kothata 100% true noy. Because whenever bile is passing through intestine, it is bound to be mixed with some other digestive enzyme. But definitely from the source itself, the Ganges at source doesn't have any impurities. But passing through here, it has everything, including corpse. Everything it has. তার মানে কি এটা যে গ্যাঞ্জেসে ওইটা রয়েছে? It's not like that. Similarly, bile, whenever it is passing through the intestine, it's bound to be some chymotrypsin will be there. But it is not the bile thing, basically. But still it is doing. But major function of bile is fat digestion. As an indirect way. কি করছে bile? Bile is causing two very important things. One is surface tension lowering. The second is emulsification, fat emulsification, and formation of micelle. তাহলে সারফেস টেনশন কি করে লোয়ারিং হচ্ছে ব্যাপারটা? বেসিক্যালি দ্য মাইসেলি ফরমেশন এন্ড ইমালসিফিকেশন জিনিসটা যেটা দাঁড়ায় যে ইট কন্টেইন স্মল গ্লোবিউলার স্ট্রাকচার bilayered. Outside is hydrophilic, inside is hydrophobic. Mostly the cholesterol and fatty things remain in the inside hydrophobic core. Remember, the intestinal solution and intestinal medium is aqueous medium. So aqueous, জলের উপর যদি আমি একটু পেট্রোল দিয়ে দিই, that will never be soluble, miscible হয় না। কিন্তু এই পেট্রোলটাকে যদি আমি একটা জলের এনভেলপের মধ্যে ভরাই, if I keep the petrol inside an envelope of water, that will simply pass through the river, কোনো অসুবিধা হবে না। So এরকম ভাবেই the bile, it is making a micelle. Micelle is just an envelope like that. It's a bilayered thing, outside hydrophilic. That's why it can easily be transported through the aqueous medium. Inside hydrophobic means it is lipophilic. Hydrophobic is as good as lipophilic. So cholesterol remains inside the core of this micelle, and then it is transported to the distal part of the intestine to the brush border where exactly this fat will be absorbed. Clear everybody? So micelle formation, saponification, emulsification. প্রত্যেকটা বইতে রয়েছে, just hammer করা এই ক্লাসের উদ্দেশ্য, and I think you can remember this. Again, this is a question, explain why. Bile doesn't contain any digestive enzyme, still it helps in fat digestion. Explain why question, প্রচন্ড common, every third year prof গুলোতে এই question এসছে, if you look back in the previous year questions. Clear everyone? Understood? Okay. নেক্সট ওয়ান হচ্ছে একটু ধরো স্মল ইন্টেস্টিনাল সিক্রিশন, বইগুলোতে রয়েছে সিক্রিশনের একটু জাস্ট যেরকম করে আমার বলা আছে যে একটা ওয়াটার অ্যান্ড সলিডস ইউ নিড টু ডিভাইড দেম, অ্যান্ড সলিডকে অ্যাগেন ইউ নিড টু ডিভাইড ইন ইনঅর্গানিক অ্যান্ড অর্গানিক. Inorganic you need to divide in cation and anion. Organic is the enzymes and the bicarbon and if there is any hormone present over there, that is the organic thing. Small intestine anatomy te tomader egulo porte hobe, just bole debo Brunner's gland that is present, crypts of Leverkun that is present, then villi, microvilli, and villi, microvilli, their main function is increasing villi main ki, that is a finger like projection close to 1 millimeter or 1.5 millimeter এরকম একটা finger like projection, and finger like projection what it does, it increases the surface area, and microvilli causes that lines the brush border epithelium, actually that helps in increasing the surface area of absorption. Again এটা histology part, but এই পয়েন্ট গুলোকে তোমাকে মাথায় রাখতে হবে whenever you are going to the examination, it should be a connection between subjects, তাহলেই বেস্ট আউটকাম তুমি করতে পারবে. অল দ্য সাবজেক্টস আর কানেক্টেড টু ইচ আদার. সো ইন্টেস্টিনাল ব্যাপারটা এটা যে কোনো বই থেকে ইন্টেস্টিনাল যে রয়েছে সেইটা খেয়াল রাখবে. এগেইন ওয়ান মোর থিং হুইচ ইজ ভেরি ইম্পর্টেন্ট, intestine are of two types, small intestine, large intestine, যার মধ্যে the large intestine is responsible for maximum volume of water reabsorption and it has clinical implication. Clinical implication কি? You all know about diarrhea, right? What is diarrhea? Lose motion. How many times হলে তখন তুমি ডায়রিয়া বলবে? More than 3 a day. Normal stool frequency কত? Again it depends on the type of food you are taking. American তারা যারা বেশি প্রোটিন মিট খায় তাদের স্টুল ফ্রিকোয়েন্সি কম, বিকজ রাফেজ যেটা রাফেজ, হোয়াট ইজ রাফেজ? ফাইবার বেশি থাকলে সেটা রাফেজ ক্রিয়েট করছে, স্টুল ভলিউম বাড়াচ্ছে. দ্য মোর ভলিউম ডেফিনেটলি মোর ইন্টেস্টিনাল রিল্যাক্সেশন, যত রিল্যাক্সেশন হবে পেরিস্টলসিসটা তত বাড়বে. সো যত রাফেজ যত ফাইবার, দ্যাটস ওয়াই যাদের কনস্টিপেশন থাকে উই টেল দেম টেক মোর ওয়াটার অ্যান্ড টেক মোর ফাইব্রাস থিং, অ্যান্ড ফাইব্রাস থিং ইজ গ্রিন ভেজিটেবলস অ্যান্ড ফ্রুটস, তাতে ফাইবারটা বেশি রয়েছে. অনেক সময় আমরা ইউজ করি ইসবগুল, অনেকেই শুনেছো, দ্যাট ইজ জাস্ট দ্য ফাইবার, দ্যাট ইজ জাস্ট দ্য মেনি 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 থিংস, এগুলো ল্যাক্সেটিভের মধ্যে পড়ে. মেনি সাচ প্রোডাক্টস ডু হ্যাভ দিস ফাইবার. ফাইবারটা খেলেই ডায়াবেটিক পেশেন্টের অনেক সময় একটু অসুবিধা হয়, ফাইবারটা খেলেই তাদের ভালো স্টুল ফরমেশনটা ক্রিয়েট হয়. সো নর্মাল স্টুল ফ্রিকোয়েন্সি ডিপেন্ডিং অন where you are coming from and what type of food you are taking, it is once in a day to 3 times in a day, this is the normal one, to once in 3 day. আমাদের দেশের জন্য once in 3 day is too harsh because আমাদের ডায়েটটা ডিফারেন্ট, বাট once in 3 day is also okay. সো যদি টোটালটা দেখি 3 in a day to 1 in 3 day, এইটা আমাদের স্পেকট্রাম. এর মধ্যে হলে উই উইল কল ইট নর্মাল. এর থেকে বেশি হলে আইদার ইট উইল গো ইনটু দ্য ডায়রিয়া স্পেকট্রাম অর ইট উইল গো ইনটু দি কনস্টিপেশন স্পেকট্রাম. ইন্ডিয়ার জন্য 1 in 3 day মানে ইট ইজ নট অনলি constipation, it is also madness. By then patient will become crazy. তো কোনো ডাক্তার তো পাত্তাই দিচ্ছে না, আমি এতবার করে বলছি, আমার তো প্রত্যেক দিন একবার তো যাওয়া মাস্ট, সেইটা না হলে তো ইন্ডিয়ার জন্য একটু এই জায়গাতে কমাতে হবে, বিকজ আওয়ার ফুড ইজ নট হেভিলি মিট বেসড. আমরা কার্ব খাই অ্যান্ড মিট ইজ দ্য সেকেন্ডারি থিং. আমাদের যে ফুডটা তাতে ডেফিনেটলি নাম্বার অফ স্টুল উইল বি মোর. কিন্তু যারা অনলি মিট বেস খাচ্ছে, যেমন ধরো তুমি মঙ্গোলিয়া চলে যাও, দে অনলি টেক মিট অ্যান্ড কার্ব নেই. -42 ডিগ্রিতে তুমি কার্বোহাইড্রেট খেয়ে ইউ কান্ট সার্ভাইভ. ওরা যেটা ইয়াকের মাংস খাচ্ছে আর ওই পুরো ফ্যাটটা খাচ্ছে, দ্যাট ইজ নেসেসারি. কারণ কার সবচেয়ে বেশি যে হিটটা ক্যালোরিজেনিক সবচেয়ে বেশি কে? ফ্যাট দিতেই হবে. -40 ডিগ্রি টেম্পারেচারে তুমি যদি ভাত খাও তাহলে সেটাই শেষ, আর 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 দ্বিতীয়বার মানে ডাল অব্দি টাইম পাবে না বেসিক্যালি. সো ওটা ওইটাই প্রসেস. ওই অ্যামাউন্টের ফ্যাট ইফ ইউ ডোন্ট পুট ইন ইউর সিস্টেম ইউ কান্ট সার্ভাইভ. কারণ একটা থেকে 1 গ্রাম থেকে 9.8 কিলো ক্যালোরি, এটাই তো ছিল. হ্যাঁ, তাহলে আর কার্বের ক্ষেত্রে 4.1 4.2 এরকম একটা এই রেঞ্জে একটা ছিল আর কি. সো ডেফিনেটলি ইউ হ্যাভ টু টেক দ্যাট. সো এই জিনিসটা দাঁড়াচ্ছে হচ্ছে এখানের থেকেই আমরা যাচ্ছি এই যে বাউল মুভমেন্ট অ্যান্ড অল দিস, ফ্রম হিয়ার উই আর মুভিং ইনটু দি 4.3, দ্যাট ইজ দি মুভমেন্ট অফ দি ইন্টেস্টিন. মুভমেন্ট অফ দি ইন্টেস্টিনটাই ইম্পর্টেন্ট. ক্লিনিক্যালি ইট ইজ কোরিলেটেড টু ইয়োর vomiting, clinically correlated to diarrhea, clinically correlated to constipation. Movement of intestine টা ওই জন্য বুঝতে হবে. নাও আর যেটা বলছিলাম আরেকটা জিনিস মাথায় রাখবে, Just by looking at the stool or type of the stool, you can differentiate between whether it is a small bowel diarrhea or a large bowel diarrhea. মাথায় রাখবে large bowel, large intestine, what is its main function? Water absorption. তাহলে যদি diarrhea is very voluminous, প্রচুর জল বেরোচ্ছে, what is that? Large bowel diarrhea. প্রচুর জল বেরোচ্ছে মানে কি? প্রচুর জল অ্যাবজর্ব হচ্ছে না। কোথায় হয়? লার্জার ইন্টেস্টিন। তাহলে দ্য ডায়রিয়া ইজ দ্য লার্জ ইন্টেস্টিন ডায়রিয়া। জল কম বেরোচ্ছে, মিউকাস বেশি বেরোচ্ছে, ব্লাড বেরোচ্ছে, স্মল অ্যামাউন্ট, বাট মাল্টিপল টাইমস দ্য পারসন ইজ গোয়িং। হোয়াট টাইপ অফ ডায়রিয়া? Small bowel diarrhea. Most of the absorption, micronutrient absorption happens where? In the small bowel. So if somebody is having chronic small bowel diarrhea, what will happen? Malabsorption, micronutrient deficiency, vitamin deficiency, anemia. If somebody is having chronic or acute large bowel diarrhea, what will happen? Dehydration, জল বেরিয়ে যাচ্ছে শরীর থেকে, and loss of certain ions. Clear? এইভাবে you can differentiate, and this way you can clinically correlate to the things. Just by this knowledge can be clinically correlated. Clear? Now coming to the intestinal movement. So first of all, one thing that is very important, remember, do you know about pacemaker? Where is that? In it's a node, a V node. So why I am talking about pacemaker in a class of GI system? What's the reason? Pacemaker is in heart. Everybody sure? Pacemaker. যারা ঘুমাচ্ছে না তারা বাদে বাকিরা pacemaker. যারা ঘুমাচ্ছে তাদের pacemaker লাগবে একটু মানে জাগবার জন্য আর কি বেসিক্যালি। আমি জানি না whether that will come from Insta or somewhere else, but pacemaker লাগে। কিন্তু এই ক্লাসে আমি pacemaker নিয়ে কথা বলছি কেন? Because GI system also has pacemaker. GI system also has pacemaker. ঠিক আছে? GI সিস্টেমে পেসমেকারটা কে করছে? ক্যাজল সেলস, ইন্টারস্টিশিয়াল সেলস অফ ক্যাজল। ঠিক আছে? এটা হচ্ছে পেসমেকার। অ্যান্ড তার মানে কি? ইফ ইউ ইট অর ইফ ইউ ডোন্ট ইট, ইন বোথ সিচুয়েশন দেয়ার আর সার্টেন মুভমেন্টস কন্টিনিউয়াসলি হ্যাপেনিং ইন জিআই সিস্টেম। তুমি তো পেটকে বলতে পারো না এই একটু ইন্টেস্টিন পেরিস্টলসিস করে দে, ইটস নট পসিবল। সো ইট ইজ ইনভলান্টারি। সো ইট ইজ ইনভলান্টারি। সেরকমই আমরা হার্টকেও বলতে পারি একটু জোরে দৌড়াতো। হ্যাঁ, ইয়শ চোপড়ার সিনেমা দেখলে দ্যাট ইজ আ ডিফারেন্ট থিং, বাট একটু জোরে দৌড়া, একটু আস্তে দৌড়াই, আস্তে হয়ে যায়, তাহলে তো হ্যাঁ হয়। মাথায় রাখবে দিস ইজ আন্ডার এএনএস, এবং কিছু রিসার্চ আছে যে ইয়োগিক সিস্টেম, যোগা, তাতে কিছু হাই লেভেলে পসিবল টু গেট সাম কন্ট্রোল অন এএনএস। এগুলো রিসেন্ট রিসার্চ, বাট ইউজুয়ালি আমরা যারা মিয়ার মর্টাল, যারা ভয় পাচ্ছি ফার্স্ট প্রফে কী করবো, সেকেন্ড প্রফে কী করবো, আমাদের সেই ক্যাপাসিটি নেই। আমাদের এএনএস ইজ রিয়েলি অটোনমিক, রিয়েলি অটোনমিক। তো সেইখানে যেটা দাঁড়াচ্ছে যে এএনএস নিজের মতনই চলবে, অ্যান্ড দ্যাট ইজ ইনভলান্টারি। তো সিমিলারলি হার্টেও যেমন এএনএস প্যারাসিম্প্যাথেটিক, সিম্প্যাথেটিক, অটোনমিক, সিমিলারলি জিআই সিস্টেমেও প্যারাসিম্প্যাথেটিক, সিম্প্যাথেটিক, অটোনমিক। রিমেম্বার রেসপিরেটরিতেও কিন্তু পেসমেকার আছে, অ্যান্ড দ্যাট ইজ ইন দি পনসন মেডালা। রেসপিরেটরিতেও পেসমেকার আছে, এবং সেটা ইন্সপিরেশনটাকে স্টার্ট করায়। ইন্সপিরেশনকে স্টার্ট করাতে হয়, এক্সপিরেশন নিজেই হয়। ইন্সপিরেশনকে স্টার্ট করাতে হয়, এক্সপিরেশন নিজেই হয়। এখানেও তেমনি, ওয়েদার ইউ ইট অর নট, পেসমেকার ফাংশন ইজ দেয়ার, অ্যান্ড দ্যাট ইজ বাই দি ইন্টারস্টিশিয়াল সেলস অফ ক্যাজল। এটা স্পেলিং ক্যাজল সেল, এরা পেসমেকারটা, পেসমেকার পোটেনশিয়ালটা ক্রিয়েট করছে কন্টিনিউয়াসলি। এবং এই যে পেসমেকার পোটেনশিয়াল, ইট ইজ বেসিক্যালি পেসমেকিংটা কি? অ্যাকশন পোটেনশিয়াল জানো প্রত্যেকে? রেস্টিং মেমব্রেন পোটেনশিয়াল ইউ নো? So that's the basics of molecular physiology. আমি যা বলছি, তুমি যা শুনছো, প্রত্যেকটা বলা, শোনা, দেখা, লেখা, এভরিথিং কামস ডাউন টু সোডিয়াম, পটাশিয়াম, ক্যালসিয়াম। সোডিয়াম, পটাশিয়াম, ক্যালসিয়াম ইনফ্লাক্স হচ্ছে, অথবা অ্যানায়ন বেরিয়ে যাচ্ছে কি ক্যাটায়ন বেরিয়ে যাচ্ছে, অন দ্য বেসিস অফ দ্য ডিপোলারাইজেশন, রিপোলারাইজেশন। দ্যাটস দ্য বেসিস অফ লাইফ, ইলেকট্রিক্যাল বেসিস অফ লাইফ। ক্লিয়ার? তো এখানেও তাই হচ্ছে, এখানে একটা কন্টিনিউয়াসলি দেয়ার potential, and it is a jumpy potential. তার যে বেস লাইন, that is not exactified. So -40 থেকে -60 মধ্যে it moves around, and this potential is known as, this is the RMP of intestinal cell, and this is known as basal electrical rhythm, BER, basal electrical rhythm, basal electrical rhythm. And this is due to, this is nothing but it is the RMP, resting membrane potential of enterocyte. This is the resting membrane potential of enterocyte. কিরম দেখতে হয়? looks like that. তার মধ্যে কোনটা BER? This part is the BER. তাহলে এই স্পাইক গুলো কি? These are spike potential. মাথায় রাখবে BER হলে বেসাল ইলেকট্রিক্যাল রিদম, এতে কন্ট্রাকশন হয় না, মাসকুলার কন্ট্রাকশন। মাসকুলার মানে কি মাসলটা? ইন্টেস্টিনে কি মাসল থাকে? স্মুথ মাসল। স্মুথ মাসল কি? ইনভলান্টারি। ইনভলান্টারি। ইনভলান্টারি মানে কি? নিউরোমডিউলেটর দিয়ে হবে, কিন্তু আমি ভেবে করতে পারবো না। আন্ডারস্টুড? চিন্তা করে করতে পারবো না। চিন্তা করে করতে পারি, খুব খারাপ করে আজকে খেয়ে এলাম, কালকে চিন্তাটা বুঝতে পারবো ফল, দ্যাটস আ ডিফারেন্ট থিং, বাট দ্যাটস অ্যান ইনডিরেক্ট পাথওয়ে। এক্ষুনি চাইলে এক্ষুনি পারবো না। ক্লিয়ার? সো BER এর উপরে স্পাইক পোটেনশিয়াল, দেয়ার আর স্পাইক পোটেনশিয়াল, এন্ড দিস স্পাইক পোটেনশিয়াল দে অ্যামাউন্ট টু মাসকুলার কন্ট্রাকশন। সো BER যতক্ষণ চলছে, দেয়ার ইজ নো কন্ট্রাকশন, এক্সট্রা কন্ট্রাকশন। টনিক কন্ট্রাকশন আছে, টনিক আর ফেজিক, দিস টু ওয়ার্ডস ইউ নিড টু আন্ডারস্ট্যান্ড। ধরো আমি দাঁড়িয়ে আছি, হাতটা এরকম আছে, ইভেন দেন বাইসেপস কিন্তু পুরো লুজ নয়, দেয়ার ইজ সাম টোন। তুমি দেখো যে মাসলটা তোমরা ইউজ করছো না, ইট ইজ নট কমপ্লিটলি লুজ, কমপ্লিটলি ফ্লুইড, দেয়ার ইজ সাম টোন। নাও ইফ ইউ flex your biceps, lifts up some weight, definitely the tone will increase. So fast যেটা কিচ্ছু হচ্ছে না, জাস্ট when totally passive, সেই অবস্থাতেও যে টাইটনেসটা রয়েছে, that is tonic contraction, that is a must. Till the time you are alive, there will be tonic contraction. And phasic contraction হচ্ছে this, যখন তুমি একটা কিছু করছো, that can be voluntary, that can be involuntary. ভলান্টারিটা হচ্ছে স্কেলিটাল মাসেলের সময়, ডেফিনেটলি জাস্ট ভাবলে তো আর স্কেলিটাল মাসেল কাজটা করতে হবে, দিস ইজ ভলান্টারি। আর ইনভলান্টারিতেও কি হচ্ছে? টোনটা মেনটেন করছে, ডিউরিং ফেজিক কন্ট্রাকশন হচ্ছে, পেরিস্টলসিস হচ্ছে, দ্যাট ইজ দি থিং। সো টনিক আর ফেজিকটা বুঝবে, মেনি টাইমস দিস টু টার্মস উইল কাম। টনিক ইজ দ্য স্টেট, বেসিক স্টেট অফ কন্ট্রাকশন, ফেজিক ইজ দ্য পালসেটাইল স্টেজ অফ কন্ট্রাকশন। ক্লিয়ার? সো টনিক পার্টটা এই BER দিয়ে সলভ হয়, ফেজিক পার্টটা স্পাইক পোটেনশিয়াল দিয়ে সলভ হয়। এবং এই একই পিকচারে আমি জানি না তোমরা দেখতে পাচ্ছ কিনা, পাচ্ছ তো ম্যাক্সিমাম দেখতে পাচ্ছ, এটা একটু গার্ড হতে পারে, আই এম নট শিওর। হ্যাঁ, যাই হোক, আমি এইখানটাতেই আঁকছি, দ্য মাসেল কন্ট্রাকশনের কার্ভটাও যদি আঁকি, দ্যাট উইল গো লাইক দিস, দ্যাট ইজ আ প্যারালাল কার্ভ। আই থিঙ্ক তিনটে আঁকাতে তিন দিক থেকেই লোক কেউ না কেউ দেখে ফেলতে পারবে। সো মাসেল কন্ট্রাকশন গোজ লাইক দ্যাট। যখনই তুমি দেখো যে মোমেন্টে স্পাইক আসছে, মাসেল কন্ট্রাকশন গোয়িং টু দি পিক, বাট অন্য সময়ও দেয়ার ইজ সাম ডিগ্রি অফ মাসেল কন্ট্রাকশন থেকে যাচ্ছে, এন্ড কন্ট্রাকশন ইজ ফলোড বাই রিল্যাক্সেশন। তার মানে কি? তার মানে দেয়ার মাস্ট বি সাম ডিপোলারাইজেশন এন্ড রিপোলারাইজেশন, যেটা হচ্ছে। সো ডিপোলারাইজেশন এখানে হয় ডিউ টু ক্যালসিয়াম এন্ট্রি, এইদিকে লিখলাম। সো ক্যালসিয়াম এন্ট্রি কজেস দি ডিপোলারাইজেশন, এন্ড পটাশিয়াম এক্সিট কজেস দি রিপোলারাইজেশন। Calcium entry, এগুলো সব MCQ. Calcium entry causes the depolarization and potassium exit causes the repolarization. So with this idea, this is the most basic idea, interstitial castle is the gastric pacemaker. It is present, এবং এটা কোন জায়গাগুলোতে থাকছে? In the myenteric plexus. Myenteric plexus, সেই জায়গাগুলোতে থাকছে। ডিফারেন্ট জায়গাতে ডিফারেন্ট অর্গান হ্যাজ ইটস ওন গ্যাংলিয়ন, ওন প্লেক্সাস, যেখান থেকে ওই অর্গানের লোকাল ফাংশনটা হচ্ছে, বাট দ্য ফাংশন ইজ ভেরি জেনারেলাইজ অ্যান্ড থ্রু আউট দি GI সিস্টেম। ক্লিয়ার এভরিবডি? নেক্সট কামিং, তাহলে আমি যদি উপর থেকে শুরু করি, টপ মানে ওরাল ক্যাভিটি থেকে শুরু করি, তাহলে আমাদের কি কি মুভমেন্ট হচ্ছে, যতদূর হবে আজকে করবো, তারপরে নেক্সট উইক করবো, ঠিক আছে? তো ওরাল ক্যাভিটিতে তিনটে মুভমেন্ট হয়, একটা হচ্ছে ডিগ্লুটিশন, যেটা আ পার্ট অফ সোয়ালোয়িং। এর তিনটে ফেজ আছে, তিনটে মুভমেন্ট মানে একটাই মুভমেন্ট, সোয়ালোয়িং, ডিগ্লুটিশন। অন্য মুভমেন্টগুলো তুমি বলতে পারো, যেমন ধরো আমরা যখন চিউইং একটা মুভমেন্ট, মিক্সিং একটা মুভমেন্ট, বাট এগুলো মোর স্কেলিটাল। টাংটাও স্কেলিটাল টাইপের, কারণ টাং ভলান্টারি মাসেল, টাং ইজ ভলান্টারি মাসেল। তোমার এই যে মাসেলস অফ ম্যাস্টিকেশন ভলান্টারি, এগুলোকে এই আলোচনার মধ্যে রাখছি না, এগুলো GI সিস্টেমের মুভমেন্ট। চিউইং, ম্যাস্টিকেশন GI সিস্টেমের মুভমেন্ট, টাং মুভমেন্ট GI সিস্টেমের মুভমেন্ট, বাট নট এক্স্যাক্টলি আন্ডার দিস, কারণ এটা ভলান্টারি এবং এটা আমাদের অন্য সিস্টেমে স্কেলিটাল মুভমেন্ট দিয়ে যাচ্ছে, সেই জন্য এটা আমরা সময় নষ্ট করছি না। যেটা আমরা আসছি সেটা হচ্ছে ফার্স্ট, তিনটে ফেজ আছে ডিগ্লুটিশন অর সোয়ালোয়িং এর। সেকেন্ড ইজ দি ফ্যারিঞ্জিয়াল ফেজ, থার্ড ইজ দি ইসোফেজিয়াল ফেজ। সো যদি আমরা যাই, ডিগ্লুটিশন মানে হচ্ছে সোয়ালোয়িং, জিনিসটাকে গিলে ফেলা, এটা তিনটে ফেজ, ওরাল, ফ্যারিঞ্জিয়াল and the third one is esophageal. এর মধ্যে oral is voluntary and that's why it is beyond the scope of today's class. এটা নিয়ে বেশি কথা বলে লাভ নেই। Pharyngeal, esophageal এই দুটো হচ্ছে involuntary। এই দুটো হচ্ছে involuntary। Involuntary মানেই there is something else that is happening। কি কি আছে সেখানে? So involuntary is usually reflex mediated। Involuntary is usually reflex mediated। এবং এই যে রিফ্লেক্স গুলো, দিস রিফ্লেক্সেস আর লোকাল রিফ্লেক্স। এখানেও ইএনএস রয়েছে, এন্টেরিক নার্ভাস সিস্টেম, এখানেও ইএনএস রয়েছে, এন্টেরিক নার্ভাস সিস্টেম। এখান থেকে জিনিসটা হচ্ছে দুটো জিনিস হয় রিফ্লেক্স মিডিয়েটেড এর মধ্যে। ওয়ান ইজ দি প্রাইমারি পেরিস্টলসিস, the second is the secondary peristalsis. So this is neuromediated primary peristalsis and the second one is the secondary peristalsis. Primary peristalsis এর function propulsion of food, লিখে নিও, propulsion of food down the esophagus to the stomach. Propulsion of food, movement of food down the esophagus to the stomach. পুরোটাই প্লেক্সাস দিয়ে রিলেটেড, পুরোটাই একটা হারমোনিয়াসলি হতে হবে। টপ পার্টটা, এই পুরো যে জিআই সিস্টেমটা না কাজটা এইভাবে করে, তোমরা যদি ছবি দেখতে পাও পুরো জিআই সিস্টেমের যে ফাংশনটা, এগুলো বেসিক। ধরো ইট ইজ আ টিউব, জিআই সিস্টেম ইজ আ টিউব, জিআই সিস্টেম ইজ আ টিউব, পুরোটা টিউব তো, এভরিবডি কনভিন্স ইটস আ টিউব, বেসিক। নাও আই হ্যাভ আ ফুড পার্টিকেল হিয়ার, এটা সব জায়গায়, গলা থেকে শুরু করে আপ টু কোলন, সব জায়গাতে এই জিনিস, ইভেন আপ টু রেকটাম অ্যানাল ক্যানাল, এই প্রসেসেই থিংস উইল মুভ বিকজ থিংস হ্যাভ টু মুভ ফ্রম ওরাল টু অ্যাবোরাল প্লেন। ক্লিয়ার? থিংস এর একটা তাহলে কি প্রক্সিমাল থেকে ডিস্টাল যেতে হবে। কিভাবে যায়? যখনই এইখানে একটা ফুড পার্টিকেল থাকে, হোয়াট উইল হ্যাপেন? দিস উইল কজ স্ট্রেচ ইন দি ফাইবার্স। দ্য মোমেন্ট স্ট্রেচ হ্যাপেন্স, দিস এরিয়া বিকাম রিল্যাক্সড and by reflex this area became constricted. তাহলে কি? there is a propulsive movement towards front and this happens throughout. clear? এই জিনিসটা পুরো সময় ধরে চলে, but different pacemakers in different region is timed differently. সেই জন্য কিরকম হচ্ছে, পুরোটা যদি ভাবো আমি একটা ফুড পার্টিকেল, এখান থেকে আমাকে ওই অবধি যেতে হবে, আমার সামনের দিকটা একটু রিল্যাক্সড হয়ে গেল, পিছন থেকে একটা পুশ এলো, আই এম গোয়িং লাইক দ্যাট। নাও আই এম ইন স্টমাক, স্টমাক হ্যাজ আ ডিফারেন্ট ক্লক, সো ইন স্টমাক আই উইল ওয়েট ফর সাম টাইম অ্যান্ড এগেইন হোয়েন দ্য ক্লক উইল ওপেন দেন আই উইল মুভ এগেইন হিয়ার। ইন্টেস্টিন হ্যাজ আ ডিফারেন্ট ক্লক, এগেইন আই উইল ওয়েট ফর সামথিং, অ্যাবজর্পশন যাকে যা দেওয়ার সব দিলাম অ্যান্ড দেন আই মুভ আপ। By now I am totally gone, but water from me is still there and that is passing through the colon. That way the whole thing is coordinated. The basic is this, but every step has a limited alarm দেওয়া রয়েছে, এইখানে এতটা সময় করে থাকবে, and that gives to the idea of gastric emptying, যেটা হয়তো পরের দিন আমরা বলবো। ক্লিয়ার? নইলে কি হতো, আমি খেলাম, খাওয়ার সাথে সাথেই আমাদের কিন্তু তাহলে ইন্টেস্টিনে চলে যেত and a large volume of thing will go there, সেটা কিন্তু করেনি because stomach is there. Number of physical and chemical স্টেক মানে চেক পয়েন্ট মাঝখানে দেওয়া রয়েছে জাস্ট টু মেক ইট হ্যাপেন। শুধু খেয়ে অ্যাবোরাল প্লেনে চলে গেলে তো হবে না, উই নিড টু টেক দ্য ম্যাক্সিমাম আউট অফ ইট। ফর দ্যাট আ স্পেসিফিক এনভায়রনমেন্ট অ্যান্ড স্টপ গেট হ্যাজ টু বি ইন্ট্রোডিউস হুইচ ইজ দেয়ার। ক্লিয়ার? বাট দ্য প্রসেস ইজ দিস, দিস ইজ দি প্রসেস বাই হুইচ থিংস উইল মুভ অন ফ্রম প্রক্সিমাল টু ডিস্টাল পার্ট। So that was the primary peristalsis. What is the secondary peristalsis? Secondary peristalsis helps in clearing out any debris or any leftover. Secondary peristalsis happens as a for clearing out any debris or any leftover. তার মানে কি, যখনই আমি খাচ্ছি, the food whenever that is present in the pharyngeal cavity or in the esophagus, primary peristalsis will convert or will convey this food, will transport this food to the stomach. But even after that, there will be some leftover which will be remaining in the esophagus. So to clear it up, second wave of peristalsis will happen, that is known as the secondary peristalsis. Clear everybody? Everybody clear? So this is the peristalsis. What is reverse peristalsis? In the opposite direction. In the opposite direction. In some cases, reverse peristalsis happens, which is the cause of vomiting. Reverse peristalsis. কখন হতে পারে? Definitely তার সঙ্গে neural connection আছে, তার সঙ্গে chemical connection আছে, and that's a separate thing. Reverse peristalsis is also possible, but peristalsis is usually due to this, and this is a phasic movement which is corroborative to the spike potential in the local region. Clear? It is reflex mediated, involuntary, we can't control. Food is so খেলে স্টমাকে যাচ্ছে, it is not gravity mediated. এটা কিন্তু খেয়াল রাখবে। হতে পারে গ্র্যাভিটি প্লেজ আ মাইনর রোল, কিন্তু যদি গ্র্যাভিটি মিডিয়েটেড হতো, নোবডি ইন স্পেস কুড সার্ভাইভ। স্পেসে গ্র্যাভিটি নেই, কিন্তু লোকে খাচ্ছে, খেয়ে ওটা কিন্তু যাচ্ছে, স্টমাকেই যাচ্ছে। সো দিস ইজ সামথিং সেপারেট। এটা শুধু তাই না, স্পেস যাওয়ার দরকার নেই, শুয়ে খেলেও পেটে যেত না, সিম্পল ব্যাপার, কিন্তু সেটাও যাচ্ছে। হ্যাঁ, ডেফিনেটলি গ্র্যাভিটি মাইট হ্যাভ সামথিং, সাম এফেক্ট, ওই জন্য শুয়ে খেলে অনেক সময় একটু অসুবিধা হতেও পারে, বাট মোস্ট অফ দ্য থিং, major factor is the peristalsis. সেটা একদম oral to abdominal direction এ continuous it will run. Clear? The next thing in this line is the stomach. So স্টমাকের ক্ষেত্রে this is the fundus, this is the body, this was the esophagus, this was the pyloric antrum, this is the greater curvature, lesser curvature, and it is going towards the duodenum, of which remember the top 1/3 is responsible for storage and responsible for tonic movement. Bottom 2/3, including the antrum, it is responsible for the phasic movement. Phasic and tonic I have already mentioned. And this is due to the bottom 2/3 is under the action of antral pump. Antral pump is just like that pacemaker which causes this extra movement. সেটা পাইলোরিক অ্যান্ট্রামের মধ্যে রয়েছে। স্টমাক is a reservoir organ. স্টমাকে কি হচ্ছে? Whenever we are taking some food, the food is getting partially digested in stomach, and more importantly, food is staying in stomach for few hours, which is helping out a lot. First of all, immediately blood এ চেঞ্জ হচ্ছে না। আদারওয়াইজ কি হতো, তুমি কিছু একটা সল্টি ফুড খেলে ইমিডিয়েট হাইপারনাট্রিমিয়া হয়ে গেল, সাস্টেনেবল নয় জিনিসটা। সো ইট শুড বি দেয়ার ফর সাম টাইম, শুড বি ডাইজেস্টেড। আর কি, ইন্টেস্টিনে গিয়ে ওই স্ট্রং প্রোটিনকে ইন্টেস্টিন কান্ট ডাইজেস্ট, তাকে আগে ভাঙতে হবে, অ্যান্ড দ্যাট ইজ বিং ডান ইন দি স্টমাক। সেকেন্ড, আরেকটা জিনিস মাথায় রাখতে হতে পারে, তুমি খাবার খাচ্ছ, সামবডি, অনেকে তো অনেকটাই খেতে পারে, অনেকে হয়তো 1.5, 2, 4, 5 লিটার প্রচুর খাবার খেয়ে নিল আর কি। স্টমাকটায় কি হয়, প্রেশার বাড়ে না কমে? বাড়ে। বাড়লে তারপরে আবার খাবার ঢুকবে। So there is something called receptive relaxation. We need to understand that. So there is something called receptive relaxation. এই রিসেপটিভ রিল্যাক্সেশন আছে বলে পুজো এগরোলের স্টলগুলো চলছে, কারণ ওরা তো এক্ষুনি বিরিয়ানি খেয়ে বেরিয়েছে, আবার এগরোল খাচ্ছে না। সো দ্যাট ইজ রিসেপটিভ রিল্যাক্সেশন। কি জিনিস? ওই দূর থেকে এগরোল দেখেই স্টমাক রিল্যাক্স করতে শুরু করে, মানে ম্যাক্সিমাম। এইটা হচ্ছে ইনভলেন্টারি। ভলেন্টারি হচ্ছে আমি খাবো না, নিজেকে কন্ট্রোল করবো, সেটা ম্যাক্সিমাম ভলেন্টিয়ারদের থাকে না, ভলেন্টারি কন্ট্রোল। এনিওয়ে, সো দূর থেকে খাবার দেখলাম, মুখে খাবারটা এলো, খাবারের স্মেল এলো, প্রত্যেকটাতে দেয়ার ইজ আ ভেসোভেগাল রিফ্লেক্স, প্যারাসিম্প্যাথেটিক একটা রিফ্লেক্স স্টার্ট হয়ে যাচ্ছে, অ্যান্ড দ্যাট ইজ নোন অ্যাজ রিসেপটিভ রিল্যাক্সেশন। অদ্ভুতভাবে স্টমাকে যত খাবার দেবে, স্টমাক তত রিল্যাক্স করবে। তার ফলে কি হচ্ছে, স্টমাকের টোনটা কমে যাচ্ছে, অ্যান্ড ইট ইজ being able to take more food. সেম জিনিস হলো অর্গান আরেকটা জায়গায় হয়, ব্লাডার, ইউরিনারি ব্লাডার। যত ইউরিন যাচ্ছে তত রিল্যাক্স করছে। সো ইন্ট্রা ব্লাডার, ইন্ট্রাভেসিক্যাল প্রেশার বলে ওটাকে। সো ব্লাডারের যে প্রেশারটা কমে, অ্যান্ড দিস ইজ গাইডেড বাই ল্যাপ্লাস ল। ল্যাপ্লাস ল দিয়ে এটা গাইড করে, যত রেজিস্ট্যান্স বাড়ে প্রেশার কমে। এটার অদ্ভুত ব্যাপার রয়েছে, প্রেশারটা কমে, টেনশনটা কমে, যত রেজিস্ট্যান্স, যত রেডিয়াস বাড়ে টেনশনটা তত কমে। দ্যাট ইজ ল্যাপ্লাস ল। সো এখানে রিসেপটিভ রিল্যাক্সেশন ইজ সামথিং whenever you are taking food, stomach is relaxed, stomach gastric pressure is going down, and that's why food can stay there for some time. কতক্ষণ ফুড থাকতে পারে স্টমাকের মধ্যে? 4 to 6 আওয়ার্স স্টমাকের মধ্যে ফুড থাকতে পারে। এন্ড তারপর যখন ফুড বেরিয়ে যাচ্ছে স্টমাক থেকে, উই কল ইট গ্যাস্ট্রিক এমটিং। ক্লিয়ার? নাও টেল মি ওয়ান থিং, গ্যাস্ট্রিক এমটিং যে হয়, কার সবচেয়ে ডিলেড গ্যাস্ট্রিক এমটিং হয়, কোন টাইপের ফুডে, আর কোন টাইপের ফুডে আর্লিয়েস্ট গ্যাস্ট্রিক এমটিং হয়? ফ্যাটের কি হয়? দেরি হয়। সো সবচেয়ে বেশি লেটে গ্যাস্ট্রিক এমটিং হয় ফ্যাট, তারপর প্রোটিন, তারপর কার্বোহাইড্রেট, সবচেয়ে তাড়াতাড়ি যায় ওয়াটার। ক্লিয়ার এভরিবডি? হলো? তাহলে ফ্যাট উইল নট মেক ইউ ফ্যাট, এটা একটা ব্যাপার। কারণ কি? ফ্যাট উইল রিডিউস ইউর অ্যাপোটাইট। ডিলেড এমটিং, ইউ উইল স্টিল ফিল দ্য স্টমাক ইজ ফুল। সেকেন্ড, আরেকটা কোশ্চেন আসে, অ্যালকোহলিকস টেক চিজ উইথ অ্যালকোহল। ওয়াই? টু রিডিউস চিজ। ওয়াইনের সঙ্গে ফ্রেঞ্চরা পুরো সবসময় চিজটা খেয়ে আসছে লাস্ট 800 ইয়ার্স। ওরা কি করে বুঝলো কি হয় প্রবলেমটা, মানে কি হয় সুবিধা? চিজ যদি তুমি নাও তাহলে কি হচ্ছে, মুভমেন্ট অফ অ্যালকোহল ইনটু দি ইন্টেস্টিন উইল গো ডাউন বিকজ অফ দ্য ডিলেড গ্যাস্ট্রিক এমটিং। চিজ ইজ ফ্যাট, so it is delaying the gastric emptying, so level of intoxication will go low, alcohol absorption টা কমে যাবে। অ্যালকোহল তো স্টমাকে অ্যাবজর্ব হচ্ছে না, ওর ইন্টেস্টিন গিয়ে অ্যাবজর্ব হবে, ব্লাডে যাবে, দেন অল দি অ্যাডিকটিভ ফিচার্স। যে তুমি হয়তো শান্তিনিকেতন মেডিকেল কলেজের জায়গায় বোলপুর স্টেশনেই বসে থাকলে, এটার জন্য ইউ নিড ইউর সিএনএস টু বি ইনফিউজড উইথ অ্যালকোহল। দি সিএনএস উইল অনলি বি ইনফিউজড উইথ অ্যালকোহল। ওটা কি হচ্ছে, এটা একটা কোশ্চেন, এক্সপ্লেন ওয়াই চিজ ইজ টেকেন অর ফ্যাটি ফুড ইজ টেকেন উইথ অ্যালকোহল। রিজন ইজ ইট ডিলেজ দি গ্যাস্ট্রিক এমটিং, ইট রিডিউসেস দি amount of alcohol being absorbed in the bloodstream and reduces the toxic or effect of addiction. Clear everybody? এটাও একটা explain why question. So এই অবধি আমি আজকে রাখছি, and we will start from here in the আমাদের এরপরে কি থাকছে, fed state movement, fasting state movement, migratory motor complex, and a little of this will be remaining. তার সাথে যদি next PY if they give, so we will continue like that. Okay, thank you.
Okay, good morning everyone. So we are supposed to start this embryology, but I thought that we have to cover up and finish up with this genetics, and then we can move through the embryology sessions. So the rest-over or leftover of the genetics which needs to be addressed and needs to be, what do I say, like needs to be covered up and emphasized, that I am just like going to do it today. So this is the final topic for the genetics in anatomy is concerned, and then on we will be moving to the embryology sessions afterwards. And we already have started with this gross anatomy, I believe. We started with the gross anatomy, right? Gross anatomy shuru hoyeche, mane we started with it. So then ki jeno bolo, oh genetics. Choke porche na keno? All right, so we already have gone through these particular aspects of genetics about this karyotyping, the bar bodies, inactivations of the X chromosomes. We understand this importance of that. We landed up in the chromosomal problems. We call them as aberrations of the chromosomes, which are of two types. There are numeric, or this numbers of the chromosomes may be error, or maybe just like we have issues with this chromosome individual itself. That's why we started with this particular numeric error of the chromosome. We call them as Down syndrome, which is an autosomal chromosomal error. We have this 21 pair of the chromosome, which is 3 in place, which is known as trisomies of the Down. And we have understand this particular Down syndrome happens with this particular problem. We call them as mosaicism. There is a cause of it, and then we call them as translocation. We call them as Robertsonian translocation. We are going to talk about today, and largely about non-disjunction, which leading to these particular formations of the trisomy of the 21 chromosome. Again, the non-disjunction as well, we are going to address. So once we understand this particular genetic error which is present to it, this particular individual who has a particular physical or phenotypic pattern. So we already have understood that this particular individual had a flat faces which is present on here, intercanthal folds are less, which has a short stature, IQs or intelligence quotients is less, the developmental error or developmental milestones are lagging behind. So this particular person also have the poor tone of the muscles. They are prone to have kind of diseases which is known as like the problem which is related to Alzheimer's. They are prone to have this particular blood cancers, we call them as leukemias. So these particular individuals have got lots of error in a system that leads to a short lifespan, and they have that like the compromised lifespan, unfortunately. So from this one we are going to talk about this particular other error which is known as the Turner syndrome, which is again involving this particular sex chromosome. So we analyze the karyotypic individual, karyotypic picture of this particular individual. We find that there is a presence of one X chromosome in a female subject and other one is missing. And we already have understood that in a female subject we have two X and one of them are active and other one is not active. We call them as a bar body. So fortunately the bar body one is missing in this individual. So if you take a kind of smear from this mucosal or buccal smear and stain it, we do not see the bar body in these individuals on the cytoplasm on this particular nucleus or this particular nuclear membranes. So that basically triggers us to understand whether this particular karyotypic problem is existing or not. If you do a detailed analysis of the karyotype, we understand this particular individual have a karyotypic picture is missing of one X chromosomes. So we call this as like XO, that means O is missing. So this is the way we represent. So this is the karyotypic or genetic makeup of this individual. Now once you have understood that, then we have to know that why this is happening. Again, same thing is happening with this particular error of this particular XO or of this Turner syndrome happening because of the non-disjunctions. We also there is another disease which is known as mosaicism, which is also leading to contribute to this. And again, it's also lead to this particular another problem. We call them as isochromosome. What is that? We are going to talk about. So if you have an isochromosome, also this particular phenotypic or these characteristics of this particular individual are represented as Turner syndrome. So we understand the genetic makeup. Now, how do this person look like and how do they present to us? The clinical problem or this particular phenotypic problem or structural problem, the persons with the female subject, we have to understand, comes to at the age of pubertal age group, or at the time the menstrual period starts, which is around like 10 to 12 years of age. So primary presentation error of this individual is that absence of beginning of menstrual period. We call them as amenorrhea. So they don't have a menstrual period beginning at the age of 15, 16 onwards. So that basically that brings us to the clinic, and we examine this particular individual who has a particular pattern. Usually these individuals are having short statures. The chest is usually broad and shield-shaped chest. They usually have or may not have, but you see that there is a characteristic waving of the neck. Some skin flap is loose hanging on the neck region, side of the neck. We call them as waving of neck. So this is a kind of hallmark or identifications of the individual of this. So if you do an ultrasound of this individual, why this particular menstrual period is not starting, we'll find that the absence of proper gonads, that means the ovary are rudimentary or not there. We call them as strict gonad. That means it's like a dust. It's not visible. Everything in the genital system is there, but the ovary is not there. And this not having an ovary, not bringing the enough output with this particular hormones which is required to have this progesterone, estrogen, etc., is not there, and resulting in the amenorrhea or the cyclical changes of the uterus is not happening. So this is how we come to the diagnosis with this particular karyotypic pattern of this and this particular problem of this manifestation. So poor ovary development, which is the hallmark, which brings us to this menstrual abnormality and eventually sterility, because ovum is not produced, which is there. Stature is short, waving of the neck is there, secondary sexual characteristics is minimal, broad shaped chest, and sexual character is also not developed because of the not having the hormones which is required to have. They may have a number of diseases linked with this particular. They have a kidney error which is developmentally produced. We call them as horseshoe shaped kidney. In short, we call them as horseshoe kidney. So this horseshoe kidney we'll talk about when you're going to talk about this particular embryological aspects of this kidney development. We talk about the horseshoe kidney or the phenomenon. So this horseshoe kidney, we see that predominantly having this particular Turner syndrome individual are suffering with. So this is how this particular thing presents. Another type of error which is known as this numeric error. We call them as Klinefelter. This syndrome, this is a syndrome which is basically happening with the male individuals. So this particular male have got extra X in their karyotypic pattern. So this particular individual, we call them as XXY or super male. They have the additional XY, X present, which is present on here. So the number of chromosome will be 47. And result of this particular X chromosome is again the same thing, is the non-disjunctions during the process of the meiosis or the cell separation process of the chromosomes. Now this particular individual having an extra X chromosome in there, they also have a phenotypic or structural pattern. So having an X chromosome, they have a pattern which is feminizing. That means the individual grows as a female character as they grow with the pubertal age, because they have high level of the female hormones in their circulating blood. So this X chromosome extra, they should not be there in this particular individual, makes this particular female part also presenting or as a phenotypic character. Usually they are tall in stature, arms are long, legs are long, looks like long athlete, just like they can run. So they have the particular slim stature. And this particular individual, they have poor or poor male sex character is developed. That means their beards and the mustache, they are not there. The hairlines are not present. So they are there because of the increased level of the female hormones. The male hairline pattern of this particular beards and mustache are lacking. And again, this particular person have got gonads which are developed, but they are non-functional. So this gonads like Turner syndrome. We talked about the strict gonad. This particular individual also, the testicles are not canalized. So in the testicles we have a tube system. We call them as seminiferous tubules, which controls or have this environment for productions of the sperm. So this particular individual have the testicles, but they are not having this particular lumen within this particular seminiferous tubules. So this particular productions of these semens are not there. So agiospermia or absence of the sperm was there in case of their kind of like a semen discharges there. So hypogonadism, there is another function which is coming with this particular agiospermia. They have this particular facial pattern, body balance error with this particular facial and hair pattern. And again, they have the female sexual characters, secondary characters growing as a male sex organ, which is coming individual, excess of this mammary gland, we call them as gynecomastia. So this particular excess productions of this particular estrogen brings us the formations of these the mammary gland in these particular individuals. And this particular individual have got like a pattern of looking like long arms, long legs, lanky looking individuals. So if you do a karyotypic individual assessment of this, we find an extra X chromosome, XXY. That's why you call them as extra X chromosome with or super male. So this is about numeric chromosomal abnormality. After that, we're going to talk about the structural chromosomal abnormality. So far we talked about the numbers of the chromosome. We count them, one less or one more will be there. In this individual, we are going to talk about individual chromosome and the error of these individual chromosomes. Now, there are several errors which is happening in case of the individual chromosomes. During this particular process of the cell divisions, there may have some kind of series of things is happening. So, one of the things which commonly happens, we call them as deletion. That means a part of the chromosome, either of the arm is partly damaged or partly washed away. So, this particular deletion of the part of the chromosome can happen at the terminal ends. We call them as terminal deletions, which is most common phase. The ends of this P arm, ends of the Q arm, that is partly damaged, which commonly happens. Or else it can happen in the mid segment of the chromosomes, which is having a fragile chromosomes, which is break prone chromosome. That happens in that case. We call this kind of deletion is an intercalary deletions. So this particular deletions can be of two types, either terminal ends or in the middle segment they are happening. And resulting of this particular chromosomes as parts, as you can see that we have a loss of the chromosome material that leads to the loss of these genes, that leads loss of the proteins, and they represent with some of the diseases in many times. So one of these things we see that is the chromosome loss in case of the chromosome number 5. You see this is the normal chromosome 5, which is the normal length. Compared to the other one, which is the other counterpart, we see that there is a shortness of the length. You look at this particular short arm here, length over here, and short arm, the length which is having on this other side is less. So this particular short arm of the chromosome, if it is lost, that creates a kind of like a summary of the diseases. We call them as cry-do-chat syndrome. So in this individual, they have a number of these kind of phenotypic presentations. Number of this particular individual have got some errors with the kids which are born with this particular problem. In biochem, we are going to talk about detail about these things. For anatomy, we are restricting on it. We just like giving an example what is happening over is chromosome 5 short arm deletions, which is a kind of deletion which is involving the terminal end. So this is a terminal deletion which is happening here. So this is one form of structural chromosomal error. Other error, translocation. What do you mean by translocation? They are changing the position. That means some was here, some was there, they are changing. So there are two kinds of translocation could be there. One is balanced translocation. That means 5 people moves from this chair and 5 people from there. They are switching between these places and there is a balanced translocation. Equal thing, right side and left side is normal in the loads of the genes and everything. Other is unbalanced. That means 3 people moving, 4 people moving from there. So there is a number of the segment of this particular chromosome. So number of the genes which has been exchanged are unequal. So we call them as unbalanced translocation. So this is the kind of thing which is happening. Let's look into it, the example which makes these things clear. So this particular translocation can be divided of 2 types, Robertsonian and reciprocal. Robertsonian translocation is an interesting phase as far as clinical genetics is concerned. I'll tell you why this is Robertsonian translocation, which is happening in between the short arm of the chromosome 14 and short arm of the chromosome 21, sorry. So 21 and 14, the short arm of this, the red and the blue we are seeing here, we focus on the short arm over there. So this particular short arm of these 2 chromosomes are separated off and this long arm uniting and forming a chromosome, we call them as Robertsonian chromosome. So, and what happens with the short arm? They are segmented out and this particular short arm, as this particular cell division takes place, we have a loss of chromosomes. So what kind of translocation is it? Balanced or unbalanced? Unbalanced. Why it is unbalanced? Because we have a loss of chromosomes or part of the chromosomes which is happening here in terms of short arm of the chromosome 14 and short arm of the chromosome 21 is segmented out and it is lost. So resulting in we are getting a chromosome which is like this, which is known as 14 by 21 Robertsonian chromosomes. Now if we have this kind of translocation taking place, this particular chromosome synthesizes some kind of proteins which is leading to the same phenotypic feature as like the Down syndrome is. So we have this particular trisomy of the 21 which is creating the Down. We also have this kind of Robertsonian translocation which is happening between 21 and 14, loss of this particular short arm leading to this particular formation of this. And if you have this existence of this kind of phenomenon of this formation, we also have the same typical feature of Down syndrome. That means the individual are Down syndrome phenotypic feature. So this is one of the reasons of Down syndrome. So this is known as Robertsonian translocation. As I am saying, this is more important because this has a clinical role. We see this kind of translocation happening in frequencies in a Down syndrome individual. That's why this is kind of this translocation important. And we see many a times questions have been asked about Robertsonian translocation, example of that and significance of it. This is one. And then brings out with this particular translocation, we call them as reciprocal. That means exchange of this particular chromosome taking place in between these particular regions and that may be associated with the balanced translocation. That means equal number of this exchange of the segment is taking place and or unequal amount. So this is happening over the 2 reasons. Now, if you have reciprocal translocation, that is yielding some kind of chromosomes. The length of the chromosomes may be of same, may not be of same. All right. So let's take this example which clears the doubts about it, what I am trying to say. So this is a translocation which is known as the reciprocal translocation, exchanging between the 2 chromosomes. More or less equal amount of this particular genetic component are exchanged. Now afterwards, if you have an equal amount of the genetic exchange or the chromosomal arm exchange, whether the length of the chromosome arms are equal or not. you see that this is an example which is shown over here. We have a translocation between this chromosome, blue chromosome, with the red chromosome. So we have these reciprocal changes over there, and roughly after the end of this translocation, see the resultant thing is that entire length of this particular, the translocated this and translocated of this are more or less equal with the same length. So we have a translocation which is a grossly very balanced translocation with the size of the chromosome is maintained. That means length of the chromosome is maintained in this. Compared to this with the downside one, you see that there is again reciprocal translocation which is taking place between this particular long arm of this and this, and again the length of this particular translocation resultant of that, the length of this particular chromosomes are dissimilar. Compare with this size, they are dissimilar. More or less they are getting the equal portions of the chromosomes, and more or less they are getting the exact same length. So this is a kind of chromosomal translocation where we get this particular length of the chromosome which is altered. So that also we have to notice. Through the naked eye, through this gene staining, we cannot figure it out unless until it is tagged. So for that we need a fluorescent microscope. We need a fluorescent microscope tagger. Once you have this fluorescent microscope taggers on these particular chromosomes, this will be fluorescent, and we can identify with a different fluorescent color, maybe orange, and with this particular green, we can judge this particular length, and if this particular length are similar or dissimilar, we can measure it. So this is how we assess this particular translocation. Again, translocation is a very important basic short note that we must understand and prepare. So basically translocation involves the two basic entities, Robertsonian and reciprocal, and total detail of these things, how this Robertsonian translocation is taking place, how this reciprocal and the balanced translocation taking place. That's what you have to write it down. Or itself, the Robertsonian translocation can be surfacing as an exam question, which is basically figuring out about this particular Down syndrome, etc., etc. All right, from this translocation, we are going to talk about something else. We call them as inversion. Now, what is inversion? That means it is inverted. That means it is switching. So, if you have a break of the chromosomes and reunion of the chromosomes, a portions of the chromosome is broken and again it is joining. So, we call this as breakage and reunion. Now, if this reunion happens in the clockwise or anti-clockwise, then we have an inversion or inverse reunion. So, this happens over here if you have a chromosome breakage involving the centromere or excluding the centromere. We call this particular breakage as pericentric inversion or paracentric inversion, depending on whether the centromere are involved in it or not. So, let us talk about this particular example over here. See, you see that this is the entire length of this chromosome. So, you see that A, B, C, D, E, these are the genes which are present in a normal chromosome. Now, we have a breakage in between these two lines, between this particular A and B and F and G, we have a break point. So, this particular segment is broken involving this particular centromere. So, this kind of centromere involved breakage with this particular reunion which is taking place in an inverse way. So, you see that this is joining with this F segment joining with F, joining with the A. So, this F segment joining with the A inwardly, whereas this particular B segment joining with this G and making it things looks invert. So, this is an inversion which is taking place involving the centromere. We call this inversion as pericentric inversion, as it is happening along the axis of the centromere. Compared to that, next kind of inversion which happens, which is excluded with the centromere. So, which is this one. We have the short arm, we have the long arm, and this particular long arm, you see that between this particular E, F, G, H genes, we have the breakage. And again, this particular thing is broken and again inverting and rejoining. That means D segment joining with this H and this particular broken E segment joining with the I. So, it is inverting and reuniting and making this particular chromosome. There is no loss of chromosome which is happening over here, only it is switching over. That means it is invertly joining. So, joining with the tail with the head, head with the tail. That is the thing which is happening. So, there is no loss of the chromosome which is whatsoever happening. Compared to the translocation, we may have a loss of chromosome or we may not have a loss of chromosome depending on balanced or unbalanced translocation. So, this is the difference with this translocation with this inversion. So, this is also similar to this particular translocation which is changing of the places which is happening there, but this is happening in a reverse way with no loss of chromosome whatsoever. And in case of this translocation, we also have the change of position, but it may be associated with this balanced or unbalanced sort of chromosomal losses. So, this is about this particular translocation which is talking about. This is again we coming here with the isochromosomes. Now, we have this particular cells in the which is going in the cellular division phase. Once we have the cellular division phase, chromosome splits into chromatids, and after this chromatids is mature and well enough, it separates and forms chromosomes and moves to the different directions. And we see that each of the chromosomes gets a pair which is coming on the P arm. It is the entire chromosome splits horizontally and goes towards. By any means, if you have a faulty separation which is separating the chromosomes only P arm and only Q arm, then one chromosome will have two P arms and one chromosome will have one Q arms. That can happen if you have the faulty kinetochore attachments or falsely attached the myospindles and it is separating out. How it is happening? This is the normal thing which happens. So, we have this particular split of this particular chromatids which is through this particular centromere, and this P arm Q arm which is there and equally divided, and it gets this two chromatids transformed into chromosomes and separated out. This is the normal thing which is happening horizontally. But by any faulty attachments of these kinetochores or myospindles, what happens in case of this horizontal, you have a transverse break of the centromere. So, it is breaking the centromere like in this point. So, what happens over here? We get these two P arms together and two Q arms towards, and then it separates. So, then we get this particular chromosome which has two P arms and two Q arms. So, this condition we call them as isochromosome because we only have P arms and only have Q arms either. So, this phenomenon we call them as isochromosome formation. This is one of the reason if you have this isochromosome or faulty separations of the chromosome, that brings up the same phenomenon which is we seen that in the Down syndrome or Turner syndrome diseases. So, individual who have this particular isochromosomes are prone to have the phenotypic picture of the Turner syndrome. So, this is one of the causes of the Turner syndrome which is non-disjunction and the isochromosome formation. So, this is what is faulty separations of this centromere which is happening place. Ring chromosome. Again, we understand the deletion and this deletion taking place in the terminal ends. Now, instead of this deletion which is taking place in one arm, this kind of deletion if it is taking place in both of the arms, that means the terminal end of the P and terminal ends of the Q, they are all broken. And if these broken arms of these particular terminal ends are sticky, they can join in each other and form a ring-like chromosome. That ring-like chromosome we call them as ring chromosome. So, this is what is happening here. We have these chromosomes, deletion happens in the terminal ends of P, terminal end of the Q, leads to these particular ends which is sticky ends, and this particular as the cell cycle moves on, this particular thing rolls and mixes terminal sticky end of the P arm and terminal sticky end of the Q arm joining together and forming a ring-like chromosome. This is known as the ring chromosome phenomenon. This is again one of the structural error of the chromosome which leads to or which is resultant from the loss of the chromosome as well or terminal deletions. So, this is a different varieties of the chromosomal error which is taking place. We call them as structural errors of the chromosomes. So, this is in short about this particular problems which is related to the structural end. Numeric end problem, structural end problem. Together we call them as chromosomal aberrations. Now, we are bringing into some different features. We see this particular entity which is coming and surfacing several times about non-disjunctions. Whenever you are talking about this particular cellular irregularity in terms of the divisions of the cell is concerned. So, what is non-disjunctions? We understand these particular chromosomes are coming to a point, reaching to a maximum length, making this kind of spindle, then they separate along breaking of this particular centromere, moving towards different directions. Now, if we have a disease or problem with this myospindles or kinetochores, where these falsy attachments of this particular strings toward the centromere leading to failure of separations of these chromosomes arms, that can lead to the problem we call them as non-disjunctions, where the separations of the chromosomes or chromatids are not properly done. That can happen any form of the cell cycles, meiosis or meiosis or type 1 or type 2, whatever it is. So this particular problem, we call them as non-disjunctions of the chromosomes, where you see that the separations of the chromosomes, which normally happens like this. In the A picture, this side, this is a normal thing. Two chromosomes splitting over here, right and left, and again this particular right splits into right, left, 1 and 2, and equal portions of this particular chromosome or genetic material are distributed throughout this particular progeny of the cells. But if you have an error like this, we have this non-disjunction which is falsely or unequally separating the chromosomes. Two of them is getting to another cell and one of them is getting nil, null or 0, and that particular cell line continues as a 0 cell, and this one is going like the double X cells. So this particular phenomenon we call them as non-disjunction or unequal or incomplete separation or impartial separations of this chromosome material. That commonly happens because of the spindles which pulls them apart. Kinetochores or myospindles are falsely attached or falsely formed. They may be associated with something. Now, why this non-disjunction happens? There are common few phenomena which leads to or triggers for this phenomenon. We call them as non-disjunction causing factors. So, one of the prime factor why we see non-disjunction happening is a normal human individual is that this particular person have got high age individuals. That means if this particular individual or the mothers, we see that advanced age is there beyond 35, 36, close to 40, this particular phenomenon or non-disjunction are more frequently seen on those individuals. So, advanced maternal age is one of the factors where this particular separation error of the chromosomes or chromatid happens. This is one of the reasons. Second thing is some of the families, they have this particular problem that runs in a genetic problem which have got faulty formations of the kinetochores or the spindles which is happening or forming and results in the same non-disjunction that runs in the families. So, this particular family suffers with this kind of problem. This is one of the things. Third thing, exposures to some chemicals, exposure to the like harmful lights, exposure to the drugs that can lead to this particular sloppy separation of these particular chromosomes. This could be the another results. And exposure to the mutagens. That means if it is produced or having some kind of chemical substance which is causing this particular chromosomal architecture or genetic architecture changes, that also yields this particular separation error of the chromosome, which is in short we call them as non-disjunction. Now, other things, we see that increased time between ovulation and fertilization. That means ovulation is done and this fertilization taking place nearly 72 hours or beyond. So, the gap between this ovulation with this particular fertilization is spaced wider. Then we see that this particular separation error also commonly happening. So, there are multifactorial reasons or more than one reasons could be there. So, one of them we identified it as this particular thing with increased maternal age are prone to have genetic problem in runs in families, exposure to the drugs, chemicals, harmful rights, etc., etc. Mutagens that is causing some kind of chromosomal changes or genetic changes that can cause and increase time span between these fertilizations when the ovum is expelled and the time it is penetrated by the sperm that can trigger these kind of problems. So, these are the causes of this. And resultant of this non-disjunction, we know that what happens if you have the non-disjunction. That means unequal distributions of the chromosomes. Some of the cells get some double load, some of the get cells none load. So, XO, XXOI, Down syndrome, etc., etc. These are the things phenomenon which is yielding because of the one of this problem we call them as the non-disjunction error. So, this is one which is happening. So, we call this as the chromosomal error which is happening between non-disjunction. Now, in our bodies we have the cell lines, right. So, we have two kinds of cell line which is present. One is known as the somatic cell, other is known as germ cells. We keep aside the germ cell because the germ cell only takes place which is in a localized point and that not contributing to these particular formations of the body because that is only for the reproduction reasons. So, in our body the cells which is all the cells which we having excluded these particular gonads germ cells, we have the 2n number cells which is double load chromosomes, normal somatic cells. And each cell, I take the cells from the skin, if I take the skin from the liver or whatever any organ, we get the same phenomenon. We get this particular 2n kind of cellular architecture which is having double load of the chromosomes which is present, which is normal architecture of this entire genetic material, whatever it is. Now, if you get an individual where we see that some of the cells have got double loads, somatic cells to be specific, some of the somatic cells have got n loads, some of the somatic cells have 3n loads. So, that same individual or any individual, we get these 3 cell lines which is present or more than 1 cell line. Some of them cells are n, 2n, 3n. So, they may have a mixture of this or maybe 2 of them. So, more than 1 cell line if it is there. Is it possible to have more than 1 cell line in an individual? Yes or no? More than 1 somatic cell line. Some of the cells, if you take it, stain it, microscope it, you see that 2n load is there. Genetic load is a 2n. Some of the cells, you see that only 1n. Some of the cells, maybe just like a 3n. Is it possible? Yes or no? If it is, show me an example. If not, story ends there. Is it there or not? Have I asked something rude or something very inappropriate? So, first question is yes or no? No. Not in a normal sense. But in any abnormal sense, can it be possible? Yes. Yes, it could be there. Okay. Anything could be there. But when? Show me an example then, which you already know. Cancer cells? Which cancer cells? Which mutation? What is mutation? I am talking about genetic loads. Show me an example. Give me a disease name or individual name who is suffering with this. You can get the cell line which is n number cell line is there, as well as 2n number cell line is also there. Colchicine toxicity. So, see that brain is a lazy organ, rather laziest organ. If you use them, you survive. If you don't use them, you ruin it, you lose it. What I see, you are not using it, so you are losing it. You are losing your head, lose your brain. I already have talked about it. I am just like asking in a reverse direction. And if I say this is what, then you say, oh yes. So, this is the last chance to use your brain or ruin your brain. Yes? Klinefelter syndrome. So, can the Klinefelter syndrome have got 2 different cell lines? N load and 2n load? No. Why no? They have non-disjunction. So, some of the cells have got more and some of the cell has to be less. How about Down syndrome? Trisomy of the 21. But some other cells, the trisomy is coming from where? God is not gifting it. It is stealing from somewhere else. So, some of the cells should be 2n minus 1. Makes sense? How about Turner syndrome, XO? Some of them will be normal, 2n, one of them will be 2n minus 1. Makes sense? So, we may have the different cell lines, or in a sense, we have the inappropriate cell line or genetic material which is present. So, this phenomenon where we have a different cell lines like this, some of them cells are n and some of the cells are 2n, or some of the cells are 3n, we get 3 different cell lines. And if this particular thing is happening in an individual, we give a special term to it. We call that particular person as mosaic. This is known as mosaicism, the phenomenon. So, this also falls in the same phenomenon. We call them as the mosaicism or mosaics. So this is what is happening here. You see that carefully. So this particular mosaicism happening because of this non-disjunction. So inseparable, this is one which is coming out. So this particular chromosome which is giving this load next progeny into two equal portions getting over here. Next division, a non-disjunction taking place in one of them, and then the other cell which is 2n already, then this particular non-disjunction, this one is happening normally, this one with the non-disjunction, one is there with the n, one is there with the 3n, and other one is 2n. So there is an existence of the three different kind of cellular lines, n variety, 2n variety, 3n variety. Same thing happens with this particular Down syndrome. This is a classic example. Then Townsend and this particular Klinefelter, which is n number 1 extra minus etc. etc. So this particular phenomenon we call them as mosaicism, where we see this particular non-disjunction taking place in not in the beginning or fast mitosis. It is taking place or phasing here in early mitotic division. That means second, third line, it is happening there. Then it gets this organism like this. Make sense? So this is known as mosaicism. So this happens here with the same zygote which is coming over here, which is fertilized and separating in an early phase of the cell division, which is splitting into non-disjunction and taking shape of this n number 2, n number 3, n number like. So more than one cellular number can be present, can be possible if you have a non-disjunction taking place early, and that particular individual we call them as mosaic and mosaicism. This is one thing. The other thing is that with the other versions of the mosaicism, we call them as chimerism, also known as chimera. So what is chimerism? The same thing. If you get this particular thing of this individual who has that different, who has the same different cell lines, more than one cell type, that means some of the cell will be n, some of the cell will be 2n, some of the cell will be 3n, 4n, etc., etc. So the cellular or genetic load within there is not of the same n type. It could be a mixture of things. Now, what is the difference between the chimerism with this particular mosaicism then? There has to be some difference between chimerism with the mosaicism, or else it would be looking like the same. Now, you see that the difference with this particular chimerism with this mosaicism is that in case of the chimerism or chimera, which is with this Greek mythological thing which is picked up form, this genetic load is coming from two different individuals. In case of the mosaicism, that is happening in the same single individual, whereas the genetic load is coming from this same individual. Now, if you have mixture of two different genes coming together from two different individuals, then we have the chimerism. Let me give an example of this. So we have these ovary. So in a cycle, in a normal human cycle, how many ovums are expelled out in a normal menstrual cycle? Single. Single ovum is there. Now this particular single ovum which is there and fertilized by sperm. So n with n together makes the zygote 2n. Normal thing, agreed. Now we have used a drug which is producing more ovum. That means ovulating drugs we are giving. So in case of the one, unfortunately, we have another M coming up. And this particular N is also been fertilized by a sperm. And together it forms 2n. And this particular things, unfortunately, if they club together, joins together and makes thing, which is this, can it happen? So when it can happen? So we call this process as in vitro fertilization. That means whenever we are producing this fertilization process in labs, the person is suffering from some diseases where this particular person or the individual or the couple are not going to have the babies, and we just bring them to the test tubes or you bring this particular labs to produce this particular thing. We call them as IVF, in vitro fertilization. So for that we give the drug, we get this particular semen, fertilize that and place it there. So in that particular process, when we just like inseminate or put the semen on it, so when this particular thing is there, we have the more than one ovum expelled out that can be fertilized to different by sperms and uniting and making this particular phenomenon, which is fusions of this thing and leading to a individual who has this particular 4n, 2n and everything mixed up. So this can lead to a complex individual. We call them as chimerism or chimera, which is a rare phenomenon, complex phenomenon, more commonly happens in case of the animal individuals, but for the human individual, it was not happening beforehand, but it is happening in the labs. Possible, could happen in case of the lags because of these particular different kind of like semens are being used, different sperms are coming over here, different ovums are coming and different directions, fertilizations taking place and the fusions and infusion taking place in the labs. We may get this kind of individual who has or suffered this kind of different cellularity at the different context. So we have the more than one cellular line, we call them as chimera or we can call them as mosaicism depending on the genetic load how it is carrying, how this thing is phenomenon. So this concludes to this particular thing about the genetics till now. If we get more time later on we can talk something else, but this is a prime thing you must prepare for the text for these particular preparations of the exams, chromosomal aberrations, non-disjunctions and the mosaicism, which is a kind of clinical questions we see that setting coming up. Though the mosaicism, we do not see this particular thing coming up, but as these things are progressing, this may show up in some other days. So that's all. Thank you.
Okay, why we called a molecules to be a reduces? What does it mean? That's mean the group containing free aldehyde and ketonic group. First thing is that because here what we talk about the carbohydrate. A carbohydrate molecules which contain free aldehyde and ketonic group is to be called reducing sugar, either reducing monosaccharide, either reducing disaccharide. What we call non-reducing sugar? Yes? Benedict reagent non-reducing sugar. My question is, what is non-reducing sugar? Yes, the compound which do not have free functional group in their structure, such like sucrose. Okay, so to identify reducing sugar in the sample, we perform Benedict test. I think you already know the principle because your Dr. Rick already tell about the principle, but you clearly, if you are not able to give the answer, it is, you understand, that is reducing sugar is reducing sugar. It contain generally 6 carbon atom. It is either glucose, fructose, mannose, lactose, whatever we talk. Reducing sugar under hot alkaline medium, that is Na2CO3, hot alkaline medium, by providing Na2CO3 we change the medium, and due to changing of the medium they forms anhydrous. Anhydrous is just a compound, and the properties of this anhydrous group is what? It is a highly reducing agent. Highly reducing agent, that means these anhydrous, what they do? These anhydrous reduces cupric ion into cuprous oxide. How it is possible? From where these cupric ions are comes? It is by copper sulfate. It is a composition of Benedict Reagent. What is the composition of Benedict reagent? Copper sulfate, sodium citrate, or sodium bicarbonate. So this reduces cupric ion into cuprous oxide. And this is basically what? This is a precipitate. This is a precipitate. Okay. So why this? What happened? By this precipitate, you confirm that the sample containing reducing sugar. So what is the application of Benedict test? To check the presence of reducing sugar in the sample. Okay. And this is our principle. Reducing sugar is treated in alkaline medium. It produces anodials, and anodials are the high reducing agent which reduces cupric ion into cuprous oxide, which is a precipitate in color, red precipitate color. Okay. Generally we call also scum, and these accumulate at the bottom of the test tubes. Okay, why we call this Benedict test as a semi-quantitative test? Why it is called semi-quantitative test? Semi-quantitative test. Why? Because semi-quantitative test, you know well, the Benedict test are not producing directly a brick red color. It is conversion of the color. The observation of this test is what? It is conversion of the color. Firstly, it is blue color. That means it is negative. Okay, this is the observation. After blue, it is converted. Firstly, we observe the change. It's converted into green color. That is 0.5 mg per dl. The quantity of reducing sugar in the sample is what? 0.5 mg per dl. Then yellow color, it is 0.5 to 1 mg per dl. Okay. Then orange, it is 1 to 1.5 mg per dl. And lastly, red, it is 1.5 to 2 mg per dl. And big red is always more than 2 mg per dl. Due to assumption of this quantity, we call this test as a semi-quantitative test. What we call this test as a semi-quantitative test. If this question asks you in your Viva, why this test is to be called semi-quantitative test, then you will tell, sir, due to the observation of color, we assume some of the quantity in the sample. That's why we call semi-quantitative test. Okay? You know the procedure of this test? How many students know the procedure of this test? Only you. बाकी लोग क्या कहाँ है दिमाग तुम्हारा? What I ask you? Now Benedict test clinical application. Clinical significance. Before doing any test, we have some motto. Motto means why there is need to perform this Benedict test. Why there need to perform Benedict test? Question is simple. To check whether the person having diabetes mellitus oblique diabetes ketoacidosis. Okay. First thing. Second one, any physiological condition. Physiological condition I will tell you in the previous class. What is the meaning of physiological condition during pregnancy and lactation? In hyperthyroidism, renal glycosuria, glucosuria. Okay, so these are the some clinical condition in which these blood sugar comes in the urine. Blood sugar comes in the urine. Why this blood sugar comes in the urine? Question is that. Question is that. So basically, students, in our kidney there is glomerular, it is for filtration, and there is a renal tubule, proximal convoluted tubule and diconvoluted tubule, DCT and PCT. What is the function of DCT and PCT? It is helpful for reabsorption. It is helpful for reabsorption. Okay. So what happened here? If our blood sugar is crosses the level of renal threshold value, that is 180 mg per dl. If the value of blood sugar crosses from this barrier, what happen here? The renal convoluted tubule not able to reabsorb all this blood sugar, and due to this blood sugar is split out from the body in the urine. So this is generally the causes. That's why these blood sugar comes in the urine. It is called either in the case of renal glycosuria when it is not related with the metabolism section. Okay. When it is happen in the case of metabolic disorder, it is called in the case of metabolic diabetes mellitus. Okay. So this is very important clinical significance of this test. Now, next is we perform test for another abnormal urine constituent. What is the meaning of abnormal urine? What is the meaning of abnormal urine? Yes, you. What is the meaning of abnormal urine? Yes.
Abnormal urine is the urine which is found when there is any physiological disease.
What is the meaning of physiological disease?
Any kind of disease or any kind of change in
Physiological is not concerned with the disease. It is pathological disease. Okay. Physiological is generally a condition of the body. It's either when a person going to be on heavy exercise, they come back from highly running condition. Okay. If any woman in a condition of pregnancy during lactation, this is called physiological condition. Pathological condition is what? When a person is suffer from any kind of disorder, any kind of pathogens. Okay. Now, second test is for identification of protein. Protein. Can you give the definition of protein? What is protein? What is protein? Yes, polymer of amino acid which are linked together by peptide bonds. You all of you know how peptide formed this form? By the condensation reactions. By the condensation reactions, peptide bonds are formed. These are generally a protein definition. When this protein present in the urine, it is known as proteinuria. What do we call a term? Proteinuria. Okay, proteinuria. For identification of protein in the sample, we perform heat. मैं लिखवाऊंगा आपको, अभी लिखने की जरूरत नहीं है. Don't write it. I will dictate you. So we perform for this test. Major test is heat coagulation. Heat coagulation test oblique heat and acetic acid test. Heat coagulation test and heat and acetic acid test. Okay, students, first you understand the terms, that is what is precipitation, and what is coagulum. What is coagulum? What is precipitate? Okay. You know, proteins are formed by a long chain of amino acid. Whether these amino acids are acidic, whether these amino acids are basic. Okay. So protein don't any protein, if any solution having proteins not forming a true solution, it's always in colloidal state. Which state? Colloidal state. When you adding any kind of salt like sodium chloride, what happened there? They precipitate the different ion from their protein structure. They precipitate the ions and they make coagulum with the water. Sodium make coagulum with the water, calcium make molecules with the water, and this condition is known as salting out. And due this, they forming hydration of the cells. Okay, so precipitate is what? Precipitate, you understand? Just simply, this is our test tubes. Okay, and this is the solution. This is our protein solution, and protein is present generally here, and these molecules is to be called any substances which can change the medium of the solution. So what happened here? They can settle down at the bottom. These molecules become settled down at the bottom by changing of the pH, is known as precipitate. Precipitate. इसको हिंदी में बोलते हैं तलछट. तलछट यानी कि दिस इज द बेस. तलछट मतलब कोई भी ऐसी चीज जो नीचे आके सेटल हो जाए. लेकिन प्रोटीन के केस में क्या होगा? बिकॉज इट इज द reactions properties of the proteins, by changing of the pH of the protein, they become settled down at the bottom. This known as precipitate. This known as precipitate. And by changing of the protein, the formation of semi-solid viscous thick material is called coagulum. Is called coagulum by change in temperature. If we change the temperature of any solution, it's form coagulum. Okay, it's form coagulum, and through by the presence of this coagulum we confirm that these having protein. Just to understand, precipitate and protein, this is the terms generally we use. It is the general properties of the protein. Now what is our test? Heat coagulation test. Heat coagulation test. What is the principle of this test? When we heat a solution, then protein loses their biological activity by changes in their structure, You know the structure classification of protein, that is primary, quaternary, tertiary and primary, secondary, quaternary and tertiary and quaternary. Okay. Change in their structure. Structure means it is converted from quaternary to primary. Lose their biological activity, lose their biological functions. Lose their biological function, such like hemoglobin. Hemoglobin is what? It is the example of quaternary structure. If we heat it, they become form, loses their biological functions, loses their bond, and they become primary structure. Same as albumin protein. Which one? Albumin. Albumin also example of quaternary structure. Okay, they loses their proteins, their structure, known as denaturation. Known as denaturation. Denaturation is what? When we provide continuous temperature to a solution, if protein is present, protein loses their structure, their breakdown of the bonds occur. What happened there? They making ultimately a single chain of primary structure. Okay, it is called denaturation. So due to this, they form coagulum. It is called, this is the basic principle of this test. When we heat a solution, then protein loses their biological activity by changes in their structure. It is known as denaturation. Okay, this is the basic principle of this test. Okay, what is renaturation? If any proteins can change their structure and after cooling they regain their shape again, it is called renaturation. Okay, so this is generally a principle of this test. You understand? Okay, now what is the procedure of this test? We take a single empty test tube. Don't write, I will tell you. मैं बताऊंगा, लिखवाऊंगा भाई क्या तरीका है लिखने का, वो बाद में बताएंगे. एक टेस्ट ट्यूब हमने लिया. टेस्ट ट्यूब में हमने क्या लिया? इसका फिलिंग 2/3 of the test tube. That's mean up to 10 ml we will take the sample. We don't know whether there is presence of protein, may be present or may not be present. We don't know about it. Okay, we take the sample, 2/3 sample. Okay, then we heat up to 1/3 portion. One-third portion. समझने की कोशिश करेंगे इसको. देखो, ये हमारी टेस्ट ट्यूब है. इसको 1/3 पोर्शन को हमने हीट किया. हीट करने पर कुछ ऐसा चेंजेस आया, कोगुलम फॉर्म हुआ. ओके, हीट फॉर 2 minutes, देयर इज अ फॉर्मेशन ऑफ कोगुलम if proteins are present. Okay, so generally which protein occur? This is confirmatory test for which protein? Albumin. Mostly albumins are generally present in the urine. Okay, so if coagulum is present here, how will you compare this? The 1/3 portion of this test tube contains same sample. How much sample we take? We take 2/3 portion of the test tube as a sample. And how much we heat? 1/3 portion only. Then rest of the sample act as a control for this upper portion. Lower portion being as a control. What is the meaning of control? When you compare the things, when you compare the test with normal things. Okay. So this is the dissolved state of protein. When you heat it, then they form coagulum. Okay. And if coagulum is formed, then you compare with this normal one, you will confirm this contain protein. What will you confirm? You will confirm this is protein, but not yet. Why? Because here you add few drops of 1% glacial acetic acid. You add 1% glacial acetic acid. Why? Because if this coagulum is formed by phosphate, sulfates, or any kind of debris means phosphates, any kind of other chemical structure, if it is formed by this phosphate, this become disappear. This coagulum become disappear. फॉस्फेट्स का होगा, अगर किसी दूसरी सब्सटेंस का होगा तो ये डिसअपियर हो जाएगा. ठीक है. अगर ये प्रोटीन का है तो ये मोर इंटेंसिफाई हो जाएगा. इट इज बिकम मोर इंटेंसिफाई. देन यू विल कंफर्म इट इज अ प्रोटीन. विच प्रोटीन? एल्बुमिन प्रोटीन. ओके. नाउ व्हाट इज द क्लिनिकल सिग्निफिकेंस ऑफ दिस टेस्ट? Clinical significance. Okay. Students, what is the function of glomerular? तेज बोलो. Ultrafiltration of plasma, blood. Okay. Glomerular is the function in which generally they going for filtration process. If there is, they can filtrate up to 70 kd size protein. Okay. Up to 70 kd size they can filter it out in the glomerular filtrate. Where? Glomerular filtrate. Then traces amount of, traces matlab minimum, traces amount of protein present in urine. We generally call low molecular weight protein. What we called? Low molecular weight protein. Okay. If there is any kind of infections in the condition of nephritis, okay, this is basically an inflammation of glomerular. Okay. Any kind of condition of AKD, we call acute kidney disease. Any kind of nephrotic syndrome, and lastly to confirm end stage renal disease, ESRD, renal disease. We confirm by this test, because if there is albumin is present, if albumin is present in high concentration means what? As Benedict test we perform, we check the quantity by changes of the color, and in laboratory report it is mentioned as positive, double positive, tri-positive and tetra-positive. This is the sign of representation of quantity present in the urine. If protein is present, it is also mentioning here for, okay. So in such huge quantity, if the protein is present in the urine, that's mean kidney having chronic condition, acute condition, mainly some of the disorder related with the nephron or kidney. It is confirmed that. Okay. So what is the clinical significance of this test? It is simple. To check the function of the kidney, we perform this. Understand? We also perform two tests for the protein. The first one is sulfosalicylic test. Second one is sulfocyclic test. What is basically what we do in this test? You understand basic principle. This is our test tube. We add few drops of sulfocyclic acid, then the protein which is present inside it changes the pH, and due to changes the pH, it going for precipitation reaction. It goes for precipitation reactions, and what happens? All the proteins may accumulate in lower sides, and the turbidity may be appear. Turbidity is appear because proteins are what? If protein is present in any solution and precipitate is present, then the appearance of this sample may be changed. By changes of this appearance, you will confirm it is positive test. It contains any kind of protein. Second test is Heller's test. How will you perform Heller's test? Again, this is our test tubes. This is our sample. Okay. We add HNO3. What is this HNO3? Nitric acid. Okay. We add nitric acid with the side wall of this test tube. Not directly up to this, side wall of this test tube. Okay. Then what happens here? There is up to 2 ml we added. There is, you will observe a change. There is white ring appear between the junction of two liquid. Between the junction of two liquid. These are the acid. These are our sample. If protein is present, they form white ring structure, white precipitate ring structure. Okay, by adding HNO3. Okay, if you add directly, what happens? They don't form any kind of ring. Means your protocol, your performance technical issues is occur. If you are not forming ring in the final result, that means you don't follow a particular standard operative procedure. Understand? That's why it is important when you add HNO3 with the side wall of this test tube. Okay? If this ring is appear, your test is positive. Okay? So this is other method rather than heat coagulation. Now make it in heading test for protein. Write it the principle. When urine sample are heated, certain biological properties are changes due to denaturations of protein, due to denaturation of protein, as a result, there is disintegration of native protein structure. There is disintegration of native protein structure. Native protein structure means what it contain. It contain quaternary structure. If it is contain quaternary structure, then it's perform their biological function. If they loses their structure, they also loses their functional capability. Okay? In disintegration of protein structure, and finally forming coagulum, and finally forming FORMING, forming coagulum. Okay? Now write down the procedure. Procedure is same. You will write in this format. First is experiment. Second one observation. And lastly inference. Okay? Experiment, observation and inference. Write it in experiment section. Fill 2/3 part. Fill 2/3 part. Fill 2/3 part of test tube with urine sample. Fill 2/3 part of test tube with urine sample. Heat the upper part portion. Heat the upper part portion and take lower part as a control. And take lower part as a control. Then add 1% glacial. Add 1% glacial acetic acid. Then add 1% glacial acetic acid. Okay. Observation में लिखिएगा turbidity in upper part of test tube. Turbidity in upper part of the test tube. In observation, turbidity in upper part of a test tube due to coagulum which does not dissolve in acetic acid. Inference में लिखिएगा protein is present. Okay, which protein mainly present? Albumin. albumin. If somebody is asking what is the conformity test for albumin, you will tell heat coagulation test or heat and acetic acid test. Okay. Now write down second test, sulfosalicylic acid test. Sulfosalicylic acid test. सल्फोसैलिसाइक्लिक एसिड टेस्ट. इसका फटाफट ऑब्जर्वेशन और उसी पर लिखेंगे टेबल बना के किस तरीके से करना है. एक्सपेरिमेंट, ऑब्जर्वेशन एंड इन्फ्रेंस. मेक द कॉलम 3 कॉलम. मेक 3 कॉलम. टेक 3 ml ऑफ यूरिन सैंपल. इन एक्सपेरिमेंट में लिखिए टेक 3 ml ऑफ यूरिन सैंपल. then add few drops of sulfosalicylic acid. 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 Okay. Observation में white precipitate appear. White precipitate appear. And in the last section you have to write protein is present. Protein is present. Now third experiment, Heller's experiment. Heller's experiment. Same 3 column you will make. Experiment, observation, inference. Experiment, observation, inference. Okay. लिखिए टेक 2 ml of urine sample. Take 2 ml of urine sample. Then add 2 ml of concentrated HNO3. Then add 2 ml of concentrated HNO3 along with the side wall of the test tubes. Along with the side wall of the test tube. Observation में white ring appear. White ring appear between the junction of two liquid. White ring appear between the junction of two liquid. Inference में protein is present. Okay. Now write it clinical interpretation. Clinical interpretation. Clinical interpretation में लिख लो फटाफट. Presence of detectable amount of protein generally. Detectable amount of protein generally in kidney disease, nephrotic syndrome, renal failure, nephrotic syndrome, renal failure, and diabetic nephropathy. Diabetic nephropathy. Okay, diabetic nephropathy. इसी में आगे लिखिएगा glomeruli are not permeable. Glomeruli are not permeable to substance with the molecular weight. Glomeruli are not permeable with the molecular weight 70 kD. The molecular weight, the plasma protein of molecular weight, the plasma proteins of molecular weight, the plasma proteins of molecular weight more than 70 kD are absent in normal urine. are absent in normal urine. When glomeruli are damaged, they become more permeable. And plasma protein appear in the urine. Which one is plasma protein? Albumin or globulin? AG ratio जो हम देखते हैं, these are plasma protein. What is the function of albumin? Blood colloidal osmotic pressure. Why blood colloidal? What is the meaning of oncotic? देखो इस लड़की को नींद आ रही है, दिख रहा है हमें, होता है कहीं दिमाग कहीं और होता है तो नींद आ जाती है. Why there is edema if person having hypoalbuminemia? Very good. Why it is comes? Because your interstitial pressure become low due to loss of albumin. Okay, that's why they can take the outer fluid to the interstitial space. It is a kind of what process? Lower concentration to the higher concentration. Lower concentration to the higher concentration. Osmosis. Higher concentration to the lower concentration. Higher concentration to the lower concentration. Diffusion. If there is a membrane is present, what is called? That osmosis. Semi-permeable transport. Semi-permeable transport. If there is protein structure is present, it is called co-transport. Co-transport. Okay? यही सब आपका चलेगा साल भर. These all are things going on in whole year. When you understand digestion and absorption of protein, when you understand digestion of lipids. ठीक है, यही साल भर आपको पढ़ना है. इसके बाद जो नेक्स्ट एबनॉर्मल कॉन्स्टिट्यूएंट है वो है कीटोन बॉडीज. ठीक है, वो नेक्स्ट टाइम हम आपको पढ़ाएंगे, अभी नहीं पढ़ा रहे, जब भी वो दूसरे फैकल्टी पढ़ाएंगे. कीटोन बॉडीज, बाइल साल्ट, बाइल पिगमेंट, these all are abnormal constituents. These generally not present in normal urine. Understand? Okay? समझ में आया सभी को? ठीक है, चलो.